Morning, Baroness Hollins.
Good morning. Good morning.
Hi.
Nice to meet you.
Hi, I'm Brent. I'm the Chief Executive.
We're live now, Brent.
Good morning, everybody, and welcome to this fourth annual conference for those of us who were in the Mental Health, Learning Disability, Autism Collaborative community across Humber, North Yorkshire. It is our fourth international conference. I'm really delighted that we've got such a good attendance and sign up to this morning's event. You may have noticed that I'm not Stephen Eames, so we've received Stephen's apologies, I'm afraid. My name's Brent Kilmurray. I'm the chair of the Mental Health, Learning Disability and Autism Collaborative in Humber, North Yorkshire, and also chief executive at TZS Gwir Valleys NHS Foundation Trust. So I'm delighted to be opening up the event this morning. Last year, when we had our successful event, we received quite a bit of feedback from colleagues and those that had participated, saying actually we'd like to spend a bit more time thinking about learning disability and autism as part of our work. So we've put a focus on that this year, and you'll see through a really exciting programme that we've put together today that coming through as a theme. We've had quite a significant sign up, so we had over 650 people commit to joining us at various points across the morning. And that's over 200 more than we had last year. And they're coming from a variety of different places across our ICS, but also from further afield, including some international colleagues that are joining us today. But we've got representatives from social care, from health organisations, providers, commissioners, the ICB, our place teams, the voluntary and community sector, the local authorities, parents, those with direct lived experience as carers, as well as service users and academic colleagues from right across those different areas. So I'll be in the chair for the first half of this session, and then I'll be handing over to my colleague Michelle Moran, who I don't think takes any introduction, and is obviously the founding chair of our collaborative. And what we're going to hear today is a range of different contributions. I'm going to have the pleasure of introducing Baroness Hollins as our keynote speaker in a moment. But also we're going to hear from some practitioners, some experts from across different aspects of the work that we do, some input from people external to our collaborative to give us some different perspectives. We'll be updating in terms of the work that we've been doing as a collaborative, and also launching our annual report today. We want this event to be interactive. Obviously, we're doing this online, which allows us to get as many of you as possible engaged with this. But please do put your questions into the chat box, and we'll do our best to address as many of those as we can as we go through. And if we can't, then we'll undertake to respond as best as we can subsequent to the event. So, and some people have already raised some questions with us, and we'll do our best to address those through the course of this morning's event. But again, we may need to follow up outside if necessary there. So I think that probably allows us to move into the agenda proper. And it's my pleasure to introduce Baroness Hollins, who is our keynote speaker today. Baroness Hollins is a psychiatrist by training and has held a number of key influential positions as past presidents of both the Royal College of Psychiatry and also the BMA. And I think importantly, current role, having been asked in 2019 by the Secretary of State to take on oversight of the independent care, education and treatment review process for those people under long-term segregation. So if I can invite Baroness Hollins to the screen and welcome you, and we look forward to hearing from you. We know that you have to leave us after your speech this morning to attend an important meeting, so we'd be grateful if we did have a chance at the end, if there were a couple of questions that we might be able to take, that'd be really great. So welcome, Baroness Hollins.
Thank you very much. And the timeliness of your event today and focus on autism is extraordinary because yesterday the report of my work on the oversight panel looking at looking into the independently chaired care education treatment reviews was actually published. I don't know whether any of the participants today saw me on Channel 4 News last night. So it's been quite a hectic few hours, really. But this also follows on from the King's speech, in which, very disappointingly, the draft mental health bill didn't feature. And this is just such a huge disappointment. And so I'm going to be talking really about what's actually kind of been happening in the worst kind of scenario where people's care and support in the community has failed, and they've been detained under mental health legislation because of being an autistic person or because of having a learning disability, and then detained in long-term segregation. And I'm going to explain some of what we found and relate it to what I think needs to be very different. So, so the next slide, the ICETR program was started by Matt Hancock when he was Secretary of State, and he asked me if I would oversee the introduction of this program, and it was because of concerns about the number of people who were in long-term segregation. I called the report My Heart Breaks. Its full title is My Heart Breaks: Solitary Confinement in Hospital Has No Therapeutic Benefit for People with a Learning Disability and Autistic People. And it has a lot of recommendations which an ICS would need to address. It's got recommendations actually the right way across the system. And as I said on Channel 4 News last night, you know, that it's not that any one part of the health and social care system is failing. There are actually some things that need to happen right the way across the system. And there needs to be a real sense of urgency and commitment and energy to try to make this work, because it can work. And there are examples in other countries where they're doing much better. Okay, and I think legislative change is one small part of it. So the government response, some of the members of the oversight panel, and it was a brilliant oversight panel with many experts by experience involved. That one in particular is very disappointed and feels rather let down by the government response. And I can understand that, but and I'll explain a little bit more about it. But it's to do with the fact that the commitments to continue the ICETR programme is only for 2 years, and that's because that's the funding that's currently available. One just hopes that at the end of 2 years, you know, there will be more money allocated so that this programme can continue. So let's have the next slide. So what we know is that there were around 2,040 inpatients in August 2023, which is quite a reduction since 2015, but it's not going to reach the 50% reduction promised by March next year. And the Transforming Care programme is definitely doing better for people with learning disabilities, but the number of autistic people are going up. And this is really interesting. I think one reason is because because autism, there's greater awareness of autism. Possibly there's more. There are more assessments being done when people are admitted in crisis now, but it does seem that there is a huge delay and reluctance to do proper autism assessments early in the community. And early autism diagnosis is really important. And I know there's some ambivalence about this. I mean, one, there's the issue about the Autism Act, and if you have a diagnosis or you meet the criteria for autism, and then you have certain entitlements, and maybe that explains the reluctance of some authorities to make early assessments. But what we know is that if children at an early age are assessed and there is early intervention, actually the outcomes for people's lives are much better. So a reluctance to do autism assessments is actually counterproductive because it's very expensive, both in terms of money, but in terms of the distress caused to autistic people and their families if everything's left until there's a crisis. I wrote a paper with 3 colleagues. All of us actually are experts by experience. I have 2 autistic adult children, one who also has a learning disability, and one of the other authors is a psychiatrist and a sibling carer, and all of the people named in the article and leading the writing of the article are people who not only have lived experience but also are actively working to try to improve the care and support for people with learning disabilities and for autistic people. Okay, so can I have the next slide? Well, so the number of autistic inpatients without a learning disability has risen by 98%, which is quite extraordinary. This is according to the National Autistic Society. What we hear in the news, and I put it here, is that it is the way that it's described by the National Autistic Society. People being restrained and kept in isolation. I'm going to explain a little bit about what the programme I was overseeing found. The shame is that the draft mental health bill could have really made a difference here. I sat on the joint scrutiny committee, a joint House of Commons and House of Lords committee, which met from January for 2 or 3 months this year, where we were looking at the draft mental health bill and making recommendations. And that bill proposed, and the Joint Scrutiny Committee supported the proposal, that that autism and learning disability would no longer be sufficient reason for people to be detained under mental health legislation. And of course, one of the concerns that's always put forward is that if people can't be admitted to hospital, they might end up in the criminal justice system. And I think that's a very unfortunate perspective, because it's in order for people's care to be improved, or for inpatient care not to be the default, often called the last resort, but sometimes it seems like it's the first resort, that people are that because adequate support and care hasn't been provided and isn't being provided in the community, that homes not hospitals is not really being taken seriously, then actually what can happen is that that on a Friday afternoon, and it's often on a Friday afternoon, that somebody is admitted. If it was just for 2 weeks for an assessment, and there was energy and commitment to help the person home by their usual team and by a really well-developed community, integrated community support from both health and social care, then admission, fine. There's concern about a mental health condition, and the person is being admitted for an assessment and for a therapeutic plan. But that's not why people are being admitted. Can I have the next slide, please? Well, my report should have been published much earlier this year, but it was delayed for various reasons. And in some ways, it's there are aspects of it that are slightly out of date because there has been progress. But the publication yesterday was accompanied by a government response, and there's an easy read letter from the minister. Unfortunately, the report itself is not been put into easy read or translated into an easy read form. The next slide. What we found is that at any one time there are about 115 people in long-term segregation. over the 3.5 years actually that the programme was running, 2 phases of the ICTR programme, 191 people received an independent review. What was kind of really disappointing was that there didn't appear to be much therapeutic purpose in people's admissions. Trauma was unrecognised. Families were labelled as difficult. People were often placed quite a distance from home. It wasn't easy for families to visit, and they were often not allowed to visit the person actually in the place where they were being kept. It was the first few that I didn't know the identity of the people. This is for legal reasons. So I would receive the report, but with the people's names and some identifying details removed. But I did a thematic review of the first 26 people. And when I read the first 1 or 2, I thought this must be exceptionally poor. But report after report after report showed similar kind of, really quite shocking failings, really. There was one young woman that I actually went to attend her ICTR, who had been in 3 hospitals in 5 months. She was still a child. She was in long-term segregation. She had now been placed 2.5 hours drive away from her home, her family home. She still had no formulation. There was no, she had been admitted following something traumatic in her family. She'd been excluded from school. And there was no expectation of a treatment plan or of any therapeutic purpose. She was seen as having challenging behaviour. Okay. That experience of being detained in that way will have devastating consequences for this young woman in terms of her own kind of relationships, her confidence, her self-esteem. It's not good enough. Okay, next slide, please. So in the second phase, 114 people received an ICTR. And of those people, despite several interventions which ran alongside ICTRs, only 48 people had moved out of long-term segregation by the end of the March, and only 7 had been discharged from hospital. Now, this is despite the ICTR, the recommendations made by them, recommendations made both to hospital managers and to commissioners. It's despite the HOPES programme, which is a brilliant human rights-based culture change and professional training programme. I recommended in my first year report that everybody in long-term segregation should receive independent case management or care management, independent, because what we discovered was that essentially there would be lots and lots and lots of people involved for an individual, but nobody was taking kind of project management responsibility to make things change, to make things happen. Nobody was coordinating a care plan for an individual. So there would be, each person would have its own identified small part of the task, but nobody was, making sure that things actually happened. And I recommended that independent care management would be a good idea. The response was for a senior intervener pilot for 15 people. And the idea was that very, very senior people who had experience of working across health and social care would be engaged to try to get the system to work better together. It's still being evaluated. It ended at the end of March. The evaluation is still being waited for. So at the moment, apart from hopes, which is still going on, I think the safe and wellbeing reviews have come to an end. They were very useful because they helped to identify how many people actually are in long-term segregation. The hopes programme is continuing, and I think it's funded for another couple of years. I'm sure that Tom Carhill later will correct me if I'm wrong on that. But the hopes programme anyway is continuing and is no doubt part of the success. But the ICTRs, what we found when we followed up with commissioners was that often the recommendations from the ICTRs were not being followed through. And this is really difficult when, whether that's due to a lack of capacity in the local system, a lack of understanding, competence amongst commissioners, it's hard to say. One of the outcomes, of course, is that there are now training programmes for commissioners, and since the Health and Social Care Act last year, there is an executive lead for autism and learning disability on ICBs, and one hopes that commissioners will be able to to take more or be more accountable for the implementation of recommendations that emerge. Can we move on to the next slide, please? So when people are admitted, if years and years ago, when I was a community psychiatrist, I worked really, really hard not to admit people to hospital. If I did, I usually admitted them to the local district, the local mental health service, and the community team worked alongside the inpatient team to try to help get that person home again as soon as possible. That's the way we worked. And we worked that way, and we were in regular contact at the time with a team in Massachusetts, which is now known as the START programme, and I may come back to that later. It's a programme which has continued to grow and is now in 17 states in America. And that was very much the way they were working as well. So we corresponded quite a bit about it, and I visited their services and they visited my services. But when somebody was admitted, to me, one of the priorities was to make sure that the person's story was known and told. And because often the person themselves was unable to explain what had happened to them, what was happening in their life, what was important in their life, and so on. But we found that people's life stories were not known. There was very little appreciation of the importance of trauma. Years ago, I did a study looking at the reasons for people's admission, and I can remember talking to a consultant colleague in probably not far from where your services are about this, and I said to him that in my experience, a lot of people admitted would have been admitted within 2 years of a parent dying. And he went and checked in his hospital and found that 50% of the people who were currently inpatients in that hospital unit indeed had been admitted within 2 years of a parent dying. But nobody had known. Nobody had made an association. The life story was not known. Okay. So there weren't treatment plans, there weren't formulations. People were not trained in autism. They did not understand about people's sensory needs. The community and hospital services were not working together. Even medication reviews hadn't been done. And when one started looking at the possibility of a person being discharged back to the community services were just not available. So it's a transforming care programme, and the discourse is really, really positive. And I know there's some really, really good examples of organisations, support providers, and services where this is not happening, where this is happening, where community services really are responding, and where community mental health teams for people with learning disabilities and for autistic people, and local providers are really working together. Can I have the next slide? What we found was that people were there because of failures in their past care and treatment. Okay. And I'm just put this slide out really to say, if you haven't read Unbroken by Alexis Quinn, an oversight panel member, then do. It's a good read and shocking, but it gives you an idea from Alexis's perspective of what the experience of being in long-term segregation for a long time has had on her own life. Can I have the next slide? So one of our key recommendations is that using long-term segregation, that the use of it must be notifiable to provider boards, commissioners and to CQC. And CQC are very keen that this should happen, but the regulations need to be changed. And I will continue to encourage government to get on with this. It's really important. I mean, one possible additional route would be that in the event of long-term segregation continuing for more than 2 weeks, that we could ask that the Secretary of State's permission should be sought. And there are precedents for that kind of initiative. So I think that's something also that, that could be thought about. Let's have the next slide. The panel recommends that all instances of enforced social isolation, including seclusion and long-term segregation, should be renamed solitary confinement. I know when we first proposed this, there were people who thought that that made it sound punitive. Actually, it reaches the, it matches the definition of solitary confinement as used in other settings. And we believe that it's important to use a correct name for it. We would like to see it ended for children and young people immediately, and we think that for adults it should be time limited. Okay. The trouble is that at the moment some people can stay in long-term segregation for a very long time. And we debated at length whether introducing minimum standards might mean that it was giving the green light for people to continue to use it indiscriminately. But we recognise that there are times when, for a person's own safety and other people's safety, that there will be times when seclusion may be necessary. The problems with changing any of these, or for introducing minimum standards or changing any of this, is that it requires amendments to the Mental Health Act Code of Practice. And because there isn't a new mental health bill coming forward, there is a risk that this will be delayed. It is possible for the Code of Practice to be reopened without a new bill, but that's dependent on political will. And so I think it's really important that people should speak up and ask for those changes to be made. I think one of the hesitancies will be that if the Code of Practice is opened up for change and for debate, then there will be other changes that other parts of mental health services will be, and the community, the wider community, will be demanding as well. And this could take quite a bit of parliamentary time to achieve, but it's urgent, in my view. Now, the next slide. So, other recommendations. It's quite a long report. It gives some, makes some suggestions about the importance of seamless care and support. One point that we felt very strongly about is that services should be seeking to deliver outcomes-based interventions, I think there's been a little bit too much of even community services being clinic-based, not relational working, not working with people's strengths and assets, not adopting preventative approaches, but rather seeing people as cases and having and providing episodes of care. These are not effective. If in a crisis, it's not appropriate to have to wait for a determination as to whether you are meeting a threshold for a particular service, or being told that you're not known to the service because the case was closed, and having to meet a new person who doesn't know you and who you don't know either. We seem to have medicalised care and support for a group of people who need a very different approach to be able to live their best and healthiest lives. And there's an attitudinal and kind of cultural change that I think is needed, and it's underway. Without question, it's underway, but that's a big education task. HOPES is working in inpatient settings, and I reckon we could probably do with a HOPES program in the community. Next slide, please. So people's stories matter, you know, they really do. What's happened in your life really matters, and knowing that somebody is interested in you as a person, you know, and is prepared to listen to you, is important. I'm going to talk a little bit about polyvagal theory very briefly, but there's a lovely article written by a former colleague of mine, Elspeth Bradley, and in Canada, about the need that people have to feel safe, and what happens if you don't feel safe. And we all need to belong. There's quite a bit in mental health research showing that, you know, there are certain things which really contribute to good mental health for everybody, whoever you are, and they include things like you know, having a reason to get out of bed in the morning. We know that autistic people have a much lower rate of employment and meaningful employment than other members of society. So having a purpose, having a meaning, having a is really matters. I don't know what it's like in your part of the world, but where I live, services are closing. My son's day centre, for example, where he was only going 1 or 2 days a week because he had other activities, closed at a day's notice, leaving 100 people without a regular day activity. He was told that it was being closed for 3 months. 6 months on, there's still no sign of it reopening, and I wonder if it will. There are no vacancies in any other services. This is really difficult for families, really difficult for individuals, when services are when the rug is pulled from under their feet. You know, when I think of the number of changes that take place in my son's life, you know, how and he finds change really difficult. Okay, I'm not going to tell you my son's story now, but it's difficult, and for a lot of people still recovering from the effects of COVID on their mental health. So much more difficult for autistic people, it seems to me, than for many others. There's something about learning to listen to people and to families, and really putting them at the centre of assessment and planning. When I first started working in learning disability, I worked with Joan Bicknell. Some of you will be old enough to remember. She was a remarkable person, the first professor of psychiatry of learning disability in the country, possibly in the world. But she didn't run outpatient clinics. She set up something called family forums. And the idea was that we would meet with the family wherever the family chose. It could be in a kind of clinic setting, a building where we were based, but it could be in the family's home if that's where they chose. And whoever was needed to be there would be there, and we would listen to people and families and find out what they thought they needed. Okay. We need to take assessment and therapeutic purpose seriously, but we need to do assessments in a timely way and not wait for crises. And you know what? We need to stop excluding people. Excluding people doesn't help. It really doesn't. It just makes ongoing exclusions more likely. Okay, let's have the next slide. So challenging behaviour. Well, I prefer to think of it as a stress reaction. Okay. And if somebody responds, this is where polyvagal theory comes in, that there are different ways in which we respond to not feeling safe. One of them is fight, another is flight. We might freeze. There's different kind of reactions which can take place, and trying to understand that this is a kind of bodily response, and that helping the person to feel safe kind of is probably the most important thing that we need to do. If we admit somebody who has been so stressed by something traumatic that's happened, by a lack of an understanding of what's going on for them and how they're feeling, that is not going to help them feel safe. That's not going to, particularly, if a lot of demands are being made by new people. There are a lot of different noises, the lighting may be difficult for them, the sounds may be difficult. It's likely that their behaviour is going to get worse. Okay, and that's not going to. Then you end up with the team in the hospital saying the person's behaviour is so bad that they're definitely not safe to go out into the community. It's all counterproductive. It's just and the length of admission, of course, is so much longer than it is for anybody who doesn't have a learning disability, who isn't an autistic person. The length of stay is kind of more than 5 years compared to, I think it's something like 28 days if you admitted with a different diagnosis. Okay, let's have the next slide. I think there has to be accountability for the outcomes of hospital admissions. If you're admitted with a fractured hip, the commissioner is going to expect that you come home with your hip repaired. So there has to be a purpose for admission, and it's no good just paying the money. And it's about knowing what is the outcome you expect of that admission. And I just can't stress enough that community services and inpatient services need to work together. START, I mentioned in the United States, has an average of 14 days for inpatient assessments and treatment compared with, some approaching 6 years in England. Why? Why? They're doing something different, doing something very different. They're working really, really hard, taking a preventative approach to working with people in the community. Next slide. So there are some opportunities for us. I think it's quite exciting. In lots of ways, I wish I was starting my career again. But it does mean knowing people, assessing people who need an assessment. It's really important to listen to your local experts by experience. I would love to see the code of practice opened up so that we can change it and change the rules to introduce minimum standards for the use of any restrictive practices. There are some good inclusive programs that we could learn from. Small Sports, National Development Team for Inclusion is running in the UK, HOPES the work that's being done in Trieste in Italy, which is fascinating. They're working with the Small Supports Programme at the moment in the UK, START in the USA. And there are others, of course. Next slide. Oh, this is just to say that the pictures I've used in my presentation come from Beyond Words, which is the charity that I founded with my son, which just helping communicating about mental health issues. I'm going to stop talking, and I'm sure you will have questions, and I hope that I haven't upset anybody with some of my direct comments.
Baroness Hollins, thank you so much for that. It's been a great start to our morning, and I think we fully accept some of your challenges, and I know that there's been quite a bit of activity in the chat box as we've been going through your presentation this morning, with people raising a number of issues, a lot of frustration about access to diagnostics and assessments, lack of community support, a general lack of understanding of autism out there within services, and a sense of isolation. So can I just check if you've got about 5 minutes before you need to go? Is that about right?
I'm fine. I think my my interview starts about in about 10 minutes.
Okay,
so
well
I'm fine.
Let's try and take a few questions in about 5 minutes. I mean, one of the things that people have picked up on, you know, in sort of a few comments that we've seen there, is this frustration around early access to diagnostics, and you've highlighted in what you said to us really the impact of that, and clearly then, you know, that leading to an opportunity to appropriate community support. You've flagged a couple of I guess examples of possible best practice there. Is there anywhere where you would point to us where they've, I guess, really, I think, made headway in that really important part of this whole agenda?
You're speaking specifically about assessment, or I mean, I love what they're doing in START in the United States, and I can tell you a bit more about that.
Yeah.
Because they it began in Massachusetts, and there was a psychiatrist called Robert Sovner working with a kind of community support worker called Joni Beasley, who's a professor and now the national kind of director of START. And as I said, she's based at a university in New Hampshire, but the program is now in 17 states, which is quite extraordinary in America, because you don't normally get kind of national programs. But their whole approach is about, so when I first visited them, it was quite fascinating, because their insurance program, sort of equivalent to our commissioners, I suppose, they'd negotiated that they had a budget for the people in their, you know, where they were working. It was on a geographical basis, but they had certain people, you know, in their patch who were referred to them, and they've had to provide a service for. The budget they got had to cover everything. So if they admitted somebody to hospital, they had to pay for that hospital admission out of their budget. Yeah. Right? What an incentive. Yeah. To keep that person at home, right? Absolutely. What an incentive. So they weren't going to waste their money by giving it to somebody else. They were going to really make sure that they found ways to keep that person in the community. And so they developed really creative, multidisciplinary, you know, cross-sector, you know, they just, and they found that relational approaches worked best. So they worked very closely. So these were, you know, these are health and social care professionals and educational professionals. You know, I remember there was one man who was admitted while I was there visiting them. The team went to the hospital. I went to the hospital with them, you know, and it was all about, you know, this is what we expect from the admission, you know. Yeah. This, you know, how are you going to do it? When are you going to do it? You know, how are we going to get him home? Right.
Absolutely.
Right?
Absolutely.
So, you know, and they are willing actually to support people in the UK. They're negotiating at the moment with a couple of different authorities in England to see if they can help to develop something similar. Okay. The work that I did was kind of not as well developed, and it was similar in that we were very community based, and I think we had a fairly small population, but we didn't admit, I never ran an outpatient clinic. If I saw somebody in the sort of the building, as it were, it was because we were running a therapeutic program. So I did group psychotherapy, kind of long-term group psychotherapy with people, and provided kind of supervision for other people to do individual relational work. But if somebody needed a multidisciplinary assessment, two of us would go to the person's home if that was the best place to be able to understand and work with them. Yeah. And we didn't discharge people because we knew that these were people with long-term conditions and long-term needs. And, you know, we would make sure that we kept in touch with them. So we would run events to bring people together, to meet us, to know us, you know. We ran conferences which were inclusive. And that's it. But I suppose a lot of that comes from me being a parent as well. Okay, yeah. So I'm not afraid of parents.
Yeah, no, absolutely. I just wonder if we could maybe just do one more question before we let you go. Lorraine Dodd has put a question in about perinatal mental health and thinking about, I guess, women with diagnosed or late diagnosis of undiagnosed or late diagnosis of autism and support for them in the when they're giving birth in maternal units, and she's advocating for autism midwives, and that's received quite a bit of support and other comments around the perinatal phase. Is that something that you have strong views on? Would you like to share your thoughts on that?
Well, again, I mentioned Alexis Quinn a couple of times. She's written a book about it as an autistic woman who's had 2 babies, and her own experience of not being understood. I think before she realised that she was an autistic woman, her first child, her first hospital admission followed that first experience of pregnancy and motherhood. But she's written a book herself about being an autistic mother, and her second child, she describes how it was different because she understood and she negotiated things with her midwife. I mean, I think, you know, we can't expect you know, there are often mental health leads, aren't there, or lead midwives. I think having an autism lead midwife would be an excellent idea. And I really would support that. My charity's has published a couple of word-free picture stories about having a baby. Actually, having a baby won the BMA Patient Information Award last year. Again, and we're about to publish another one. But the reason for it is because it gives some pointers to the midwives and health visitors as well as to the person themselves about how one may need to communicate differently, think differently about ways that women will need to be supported, so that it's a good experience for them. And you know, traumatic births are not, you know, they're too common, but they're probably more common for autistic women. Yeah. So I think it's a really, really important idea.
Thank you very much, and thank you very much for everything you've done for us this morning in terms of setting us away on an important set of conversations around autism. We wish you well with the recommendations. We look forward to engaging with them as a system here and working things forward. So thank you very much.
Thank you. Well, thank you for having me, and do read the report.
Absolutely.
All right.
Thank you.
Bye-bye.
Bye-bye. So without further ado then, so thank you, as I say, to Baroness Hollins. There's obviously thank you for your comments and questions in the chat, which we will be collating and looking through. And if we can, you know, we'll be providing some commentary and response to them as we I guess progress post the conference this morning. Moving into the next section, I'm going to pick up a slot here around updating on the work of our collaborative. Those of you, if you could just move to the next slide, that are from Humber, North Yorkshire will be aware that we cover a big patch. I think we are actually officially the second largest ICS in England, covering 6 places and a whole range of communities, supported by primary care, the voluntary and community sector, and thousands of NHS and social care staff across our patch. I'm delighted if we can just move to the next slide to acknowledge, I think, that our collaborative is the longest standing, if you like, provider collaborative in the area. And Michelle Moran, who I mentioned earlier, was the founding chair of that, and has brought together a range of different players that you can see mentioned in that infographic there, that ensures that we cover the full range across the system. So we have representatives from all of the key providers, and we have representatives from each of the 6 places and the ICB there. And when I talk about the providers, I mean the NHS, social care, voluntary and community sector, and so on. We work across the ICB, and we're engaging with the ICB currently to look at the work that we're doing and thinking about how we can further improve on that and take it forward into its next phase of development. So perhaps more of that on another occasion. Next slide. So here is a summary of our priorities. Some of those will be, I think, familiar to you. Those that you're familiar with a long-term plan, you will recognise some of the key items there that we will be, I guess, addressing on that basis. But also what we're trying to do is to make sure that that's responsive to our local communities and the needs that we see, which are slightly different in each of our different places, as you'd imagine, and within those places. What we try to do through our collaborative and our work in each of these areas is we try to draw together our ideas and engage with our communities to make sure that we can develop plans that we can work through and agree the allocation of funding. We've drawn in significant sums of money into each of these areas that have allowed us to invest in developments to move these really important agendas forward. We have the opportunity to make sure that as a leadership community around this agenda, we can assure each other of the work that we're doing. We can look at best practice, and we can think about how we can support each other in monitoring progress and providing any additional support or input where we fall behind in any case. But actually, I think our story is a really positive one of some key achievements. So I'm just going to touch in the next slide, next few slides around some of those key achievements. I'm going to start off with community mental health, which is obviously one of our biggest service areas as organisations across the 6 places. Community mental health transformation is one of the sort of major steps, I think, that we're taking within the sector around reform and transformation. What's proposed and what we're working through is significant, and I think it will, to use that horrible phrase, change the game really in terms of how services are delivered, and certainly how services are experienced by people who use them. In most of our places, we're developing a wider range of provision, thinking about how we draw together different aspects of care and support for people, sometimes in community hubs, sometimes around primary care, so that we can ensure that we're meeting the wider needs of people earlier within their journey. That draws on some of the lessons that we've learned through our engagement with the Trieste system over the years, thinking about how we can be more person-centred, more holistic in the support that we offer. The slide there, it draws out some of the specific work that we've done around the additional roles that we've put into primary care, which allow us, I think, to get some of that support sooner in the process. And there's a whole series of steps that we've taken which are associated with that, which allow us to provide a stronger navigation of the system to support people. I'd particularly like to acknowledge the input and the support that we've received from the voluntary and community sector and social enterprise in the development of some of these services. And I think that that's really a positive development that we are seeing now roll out more prevalently across our places. And I think what's important when you look at this slide is you can see that the steps that we've taken within Humber North Yorkshire show that we are leading the way really across the north. Next slide, please. So moving into children and young people services, some really helpful quotes on that slide, but obviously in Baroness Holland's talk, she talked about trauma, and we are very clearly aware around trauma and the importance of developing more trauma-informed care. And this pilot project that we've engaged with has been really successful, engaging a large number of people, working with them in a trauma-informed way to support them. And you can see that it's already having an impact on those young people that are at risk of getting into the criminal justice system. And we're starting to see a reduction in reoffending rates for those young people. Next slide, please. A couple of items here on physical health. Obviously, we know that physical health, runs directly alongside mental health, and it's really important that we support through these key initiatives how we address health inequalities in the client groups that we work alongside. And you can see that we've actually made some significant progress here in improving on our position in terms of both the annual health checks for people with learning disability and autism, by achieving 82.6% this year of those health checks. And if Tom Cahill were here, which he will be later, he'd be saying, well, what about the other 17.4%? And clearly we will be focused as we work through our plans for the coming year. And equally for those people with severe mental health needs, providing more physical health checks for them. You can see we've taken a step up there as well. Next slide, please. Just wanted to reflect for a few minutes on the Resilience Hub. We are really proud about the way that we pulled together as a partnership to establish and make a success of this Resilience Hub. And the focus of the Resilience Hub is around providing support in a timely way, in a focused way, to colleagues that work within health and care. It came out of the pandemic. It's been supported subsequently. We're now looking at reviewing how we might be able to sustain this now that the funding has expired around it. But we know that post-COVID, well, through the pandemic and post-COVID, there's been a serious impact on staff well-being and ongoing concerns about staff mental health. The Resilience Hub is a partnership project provided by all of the different organisations from across Humber North Yorkshire, where we've been able to provide a very timely support and to quite a high level of need. I think probably is something that we would reflect in our experience of providing this service. You can see that it's been broadly and widely supported by those that have used it, and there's some great quotes there really around people's experience there. Next slide. We'll circulate these slides so that you can have a look, but what we wanted to do is just to articulate that what we're trying to do as a collaborative, and we're presenting it here through this slide on a page, this plan on a page, is to highlight that we're trying to draw together the national agenda and national programmes with what we acknowledge are our local priorities, and you can see how we've set that out there in making those links. We form part of the integrated care system, but we work very closely with the Integrated Care Board in terms of the development of our operational plans, and that's how we feed in, if you like, through our governance to the system that we work within. Next slide. I'm really proud of how active and engaged our wider clinical community is in the agenda that we're working on. We've got a very, very vibrant clinical assembly that is co-chaired by Stella Morris and Steve Wright, and it comes together on a regular basis and is covered, a wide variety of different issues that have required us to develop our thinking, and they're providing us with some thought leadership and some guidance in terms of the way that we can progress in some of these areas. And you can see that they've covered mental health and primary care, physical health, trauma-informed care, eating disorders, neurodiversity, and a session on power, threat and meaning. There's also been a session there around inpatients and some of the work we're doing on quality and alternatives to admission there. A really important part of what we do, and I'm grateful to colleagues that participate in that, which allows us to move that forward. Next slide, please. We've touched on this already this morning through our keynote speaker, and we know that autism diagnosis is an area, and assessment is an area of national concern. The demand that we've seen for those services has significantly increased. We know that we are far exceeding the national target of 13 weeks, and that's the experience across the country largely. There's a need for us to think about new approaches to this, and this is certainly a priority for us as we stand now and will be over the coming months. Next slide. There is a definite commitment for us to improve this and to work this through. There is a new autism and assessment framework published. I think that many of us, and I would reflect that this can be improved, that we need to work together to co-create a more equitable and timely response to this, so that we can get a high quality and sustained approach to making sure that we're in a position to identify people's needs and then work with them in a purposeful way to meet their needs. I appreciate that there's been some feedback about steps the ICB has taken, certainly within North Yorkshire and York, and I know that that's caused people some anxiety and concern, and I would acknowledge that and make a commitment that we're looking forward to unpacking some of the feedback, working through the pilot feedback, so that we can think about how we can make improvements and work that through our pathway steering group to make sure that we can put in place the best possible approach that we can within our system going forward. Next slide. Just wanted to draw out that obviously there are some great examples on the patch around how we're working with people with autism. Really grateful to Care Plus, the providers of these services in North East Lincolnshire, and thanks to Jane Miller and her team for sharing this example. I think it does demonstrate the benefit of collaborative working, that we can share some of this learning, and clearly there's examples here that we can all benefit from across our 6 places. And as you can see in this example, this is about diagnostic and ongoing support for people, local peer-led working, providing one-to-one support and group led support and training on understanding, supporting people as we go through that journey there. So something I think that we could I think usefully spend more time in terms of sharing some of the learning on. So that brings me to the end of my overview, really, of the progress that we've been making as a collaborative. If we can move to the next slide. We are pleased today that we are launching our annual report for 22-23. Each and every one of you will be getting a link to that, so please do have a look at it. If you've got any questions or thoughts on it, then the team will definitely be keen to hear from you. But thank you very much for all of your support, for everything that we've been busy with over the last 12 months or so, and we're looking forward to continuing to work with you on all of these important priorities over the coming period. So thank you very much. That's all from me at this stage. So I don't know if we've had any questions while I've been talking. I haven't been able to follow the chat as we've been going through. But if any colleagues wanted to draw out anything from the questions that have been coming through. No.
Good morning, Brent. I think there's just a couple around, obviously, our objective. Good morning, everybody. Michelle Moran, Chief Exec. Great presentations, great resume, Brent. Just a couple about community transformation and whether it's placing stress on inpatient units and what the collaborative have been thinking about that. So maybe a bit of crisis work might be helpful, Brent. I think you touched on it, but picks a few of the questions up. But obviously, as you said earlier, we'll get back to everybody. We'll do a bit of a resume and feedback the questions. Thank you. Okay, Brent.
Yeah, thank you for that, Michelle. Appreciate you summarising that one. So yeah, absolutely. In terms of community transformation, well, it's designed absolutely to do the opposite, to try and relieve some of the pressure or the need for admission as we work through. Obviously, it's still quite variable in terms of the way that that's rolling out across our communities. What we're trying to do is to link that with some of the work that we're doing around changing care planning and care coordination and those sorts of issues. The other aspect to it, of course, is Michelle just mentioned, is crisis transformation. We are currently piloting different approaches to how we're managing crisis calls. We've seen a significant increase in the demand for crisis. So as we develop community transformation, I'm hoping that we will be able to abate and alleviate some of that as we work through. We are looking at different models in different places. One of the things that's currently underway is the 111 Press 2 pilots, which we're obviously getting some early feedback from, and there are definitely opportunities for us in terms of learning around that. But certainly, it is an area of key priority for us over the coming period, and we'll be working through on that. So thank you very much for that question. Unless there is anything else, I think I'm going to move us to our break slightly early. So let's take our break. Let's come back at 10:35 and then we'll resume our conference with our showcase from colleagues. Jill Corbin, Director of Neurodiverse Connection, will be joining us, and I'll look forward to introducing colleagues when we come back. Lindsay Webster and Anne-Marie Marin and Jill Poole. So please come back promptly at 10:35 and we will get going again with the next section of our conference this morning. So thank you very much. Okay, welcome back everybody, and thank you for all of your contributions in the chat. It's quite a vibrant conversation, and as we've said earlier, we will engage with all of them and bring them together so that we can provide you with some feedback on those questions, and also offers of help, which is great to see. So thank you for that. So we now move into the next section, which is the showcase from Humber, North Yorkshire, joined by a range of great colleagues who are going to take us through some of the work that they've been doing. We've got Jill Corbin, who will be talking to us about lived experience and some of the work that her organisation has been doing in that regard. Jill is a person who has autism, and we'll be talking about some of her experiences as we work through. We've got colleagues from our Humber North Yorkshire Key Worker Service who work with children and young people with learning disabilities and autism. And we have Jill Poole, who's from Matthews Hub, and that's a support service in Hull for people aged 13 or over who are autistic or have ADHD without a learning disability, and are those awaiting diagnosis. So looking forward to hearing from each of you, and we'll obviously have an opportunity to get into some questions and answers after we've heard from you. So Jill, I'm going to hand over to you initially. So welcome. I know that I think you have connections to this area through your family, and we've had the pleasure, certainly in Tuve, of hearing from you and your experiences. So I'm really looking forward to hearing what you've got to say. So Jill, over to you.
Thanks so much, Brent. Great to be here. If I can move us straight on to the next slide, please. So I'm Jill Corbin. As Brent said, thanks for the intro. I'm autistic. I'm the director of Neurodiverse Connection and have done quite a lot of work with inpatient services, with community services, particular focus on sensory environments, and working with autistic people and the teams around them. If we can move on to the next slide, please. Go on in again. Lovely. Okay. So I'm particularly keen to be here bringing a lived experience perspective. There's this beautiful quote from the late Donna Williams, and Donna pointed out that right from the start, from the time someone came up with the word autism, it's been judged from the outside by its appearances and not from the inside according to how it's experienced. It was interesting hearing Baroness Hollands this morning. I think she spoke to some of this. And I was asked to share on good practice, and really the good practice that I wanted to reflect on wasn't the individuals that I've worked with, because their stories are not mine to tell, but the fact that the Yorkshire and Humber Transforming Care team had engaged my organisation, though this it could have been others, but to bring that lived experience perspective. And I'm going to talk more about why that's important, what difference it makes, and how our sensory social processing, our perceptive reality materially differs from neurotypical people, and why that lived experience, understanding that kind of translation, can be really, really important, particularly when people are having difficult times and when teams are struggling to work effectively with people. So if we can move on again, please. So some of you may be familiar with the very brilliant Damien Milton's double empathy problem. And I think this really is at the heart of why that lived experience perspective, why that translation, why it's important to have somebody who can speak both languages. I've heard autism as being like a different computer program, or it's like having an Apple iPhone versus an Android. You know, that they're both great, they both function well, but you try and marry the two or talk between the two different types, and it can be really challenging. And there's a misunderstanding, I think, that autistic people lack empathy. There is some research say autistic people lack empathy. The empathy quotient is still part of the diagnostic criteria. And Damien and his team did some research, and what he did was he spoke to autistic people, and he found actually autistic people could empathise really, really well with other autistic people. And he found that neurotypical people or non-autistic people could empathise really, really well with other non-autistic people, but that actually there is a cross-empathy problem. So when you take someone from one group and someone from another group, a neurotypical person and an autistic person, and try and get empathy between the two, that's where there's the gap, or the struggle to understand, or the lack of empathy, because people have such different lived experience, such different processing, and such different sensory and perceptual reality. And I think what I see in a lot of my work is that autistic people are judged by neurotypical norms rather than understood from our strengths and our differences and the way that we work. So I often say to teams, actually autistic people, like, we have a different sensory reality, we have a different communication norm, and we have different cultural norms, and so it's really, really important to get training, but also to work alongside people to really understand, actually, if somebody's, I don't know, for example, damaging walls, like is that challenging behaviour, or have they got hypersensitive proprioception and are seeking additional feedback? So our starting points and our understandings can be quite different. If we can move on to the next slide, please. Okay, so I think it's really important to nod to some of the traditional understanding and approaches, and I still see this very much in services that I work with. And I think we're really also starting to see a movement away and increased research away from this. So autism is characterised as a disorder. So I identify as being autistic, but I don't identify as being disordered. I appreciate this is kind of medical terminology, but actually I think we can talk about autism rather than ASD. I don't think that's a big switch. There's a real kind of deficit model and focus on impairments. So, for example, I might be told that I have a deficit in my social communication skills, whereas I could equally say that many neurotypical people, they might be disordered in autistic communication skills. They might not have this kind of depth of interest, depth of focus, ability to concentrate on single topics for a long amount of time. But actually, we can reframe that. We can recognise the differences without being deficit focused. I would love to see a movement away from functional labels. Many people would identify me, I think, as high functioning. That's what my autism diagnosis said. But there are many areas of life that I really struggle with, and I feel like the functioning labels underestimate the support needs of those of us who are high functioning. And like really reduce and limit the capacity and capabilities of people who are deemed low functioning. And actually, we are all diverse, varied human beings. You know, many of us need help in life. So yeah, so a movement away from that and actually looking at particular strengths and challenges, I think, could be really helpful. Again, Baroness Hollins spoke to a little bit about the behavioural understanding. So yeah, I think this kind of looking at autism from the outside, this outsider perspective, this focus on kind of bad behaviour, but also the behavioural recommendations. So being met with a PBS plan, for example, to me, that's an immediate indicator of somebody perhaps not really understanding the lived experience and not really understanding sensory social processing, and yeah, that kind of that insider perspective. Focus on neurotypical norms. So many of us still judged by our ability to make eye contact, for example, our ability to engage in neurotypical preferences for communication, our ability to manage a range of tasks at one time. And a lot of us can function pretty well for a short amount of time, meeting these expectations, but actually it's hugely exhausting. So again, I often talk about, I went through a lot of my life not really understand. I was only diagnosed less than 3 years ago, and I went through most of my life not understanding that it's like playing a computer game and not realizing that it was on the hard setting. But yeah, the diagnosis has been really hugely beneficial for me, to understand actually what are my needs and how can I meet them. And finally, I think the accumulation of these traditional understanding and approaches means that our needs are often not met. Our distress escalates, we go into fight flight, and this is sometimes met with coercive practices, restraint, seclusion, segregation, and behavioural approaches, including the withholding of things that are important to us. Yeah, and again, Baroness Hollins spoke to that this morning. If we can move on again, this is a bit of a fly through because we've only got 20 minutes, but I will see how far we can get. So I always talk about sensory and social processing differences when I talk about autism. I think, you know, it has traditionally been characterised as a behavioural disorder, but actually we're really understanding now that many autistic people, the majority of autistic people, have hyper, so increased, or hypo, decreased sensitivity to our external senses. So for example, when I'm under bright LED lights, I feel like the light is filling my brain and it's pushing all of the words and all of my other functioning out. So after 2 to 3 hours under the bright white LEDs that you might get in hospital, in GP surgeries, in schools, in supermarkets, in many kind of shared spaces, but probably not in your own homes, I really lose functioning ability and become very dysregulated and unable to process spoken word. Many of us can hear and sense more than other people. So, for example, with our hearing, not only, if we're hypersensitive, not only might we be able to hear more, a greater range, and you know, voices down the corridor, classically, what people are saying in other areas of the house or the building, but also we can't filter noise. So if there is a background noise, I'm not able to filter that. So all of the time I can hear that noise, I'm processing it. And so again, thinking about our brains as computer systems, it's hugely exhausting and very demanding to process all of this all of the time. And so a lot of us have increased sensitivity and can't filter it. So very often when I'm going into people's homes to do sensory environment reviews or going into hospitals, I'm identifying heat noise from heating, from air conditioning systems, the the type of lighting, the colour of the bulb, the glare, the reflected glare from gloss walls or from floors that are likely to be contributing significantly to somebody's ability to process information, their discomfort in a space, and all of this is adding to dysregulation. If we go on to the next slide again, please. Okay, so as well as our external sensors, we have internal sensors. I could speak for a day on each of these slides, but just to give a top line. So interoception is our internal messaging system. What am I feeling? Am I the right temperature? Do I need the toilet? Am I hungry? Am I angry? Proprioception is where is my body in space? And a lot of us have hyposensitivity or not enough sensitivity on where our body is in space, and a lot of us might cross legs, hold our bodies, want heavy rucksacks, or in more extreme cases we might also hurt ourselves to bring that regulation and to provide that additional information and input. And the vestibular sense, which is our balance. So you'll see a lot of us kind of holding walls and that kind of thing. And all of this combines to the world being, you know, it can be really, really challenging to go to a new space because I don't know what what external sense I'm going to be hit with. You know, is it going to be very noisy? Is it going to be very bright? And the more noise and bright light I'm under, the harder it is for me to process my interoceptive signals, to know what I'm feeling and to regulate. And so what you see very commonly for autistic people, particularly when we're in difficult sensory and social environments, is that we get this alexithymia, challenge to know what we're feeling. And we go from, it looks like we go from 0 to 100. You know, it's like they were fine, but then in a moment they were overwhelmed. And probably what's been happening is there's this cumulative overwhelm, but we're not able to process it at the time because we have monotropic processing and can often only process one thing at a time. We're not noticing that we're becoming dysregulated and overwhelmed until it's too much, and then we need to get out of there. And if we go on to the next slide, please. And this is where, again, I'm echoing Baroness Hollins and polyvagal theory, but with flip-flops. So this is fight, flight, freeze, fawn and flop. So what we see is we get dysregulated. So we're overwhelmed and we go into meltdown. So that is fight, flight, and often in services, those are the people who I'm often kind of asked to work with. Those are the people who are often known to services. These are the people who are often experiencing 4-to-1, 5-to-1. These are the people who are often experiencing long-term segregation. These are the people who are often experiencing psychotropic medications. Those of us, I'm of the freeze variety. Those of us who freeze are often seen to be compliant. We're often overlooked. Our needs are often not understood. But again, echoing Baroness Hollins, like this is distress, this is overwhelm, and I think what often isn't understood for autistic people is that how much impact the sensory and social environment has on our ability to regulate. I think I'll leave it there on that slide. If we go on to the next one, please. So, who's autistic? Really, really important. Apparently 1.1, this is widely acknowledged to be an underestimate, that 1.1% of the population is autistic. And it's really, really important that we're diagnosed. And I appreciate the nod, Brent, that you gave to this, but I think part of our good practice is to acknowledge when we're not getting it right. And I'm really concerned at the restricted access to autism and ADHD assessments that we've heard about in York and North Yorkshire, and I'm really pleased to hear that's going to be reviewed. It's worrying, and we know that it caused harm. And the part of the reason that that this is important is because we are at increased risk. We're at increased risk of homelessness. We're at increased risk of experiencing sexual violence, of PTSD. We're more likely to die early, and we're 8 times more likely to die by suicide, and that increases to 13 times for autistic women. And as Brent said, I've been doing a little bit of work with TESASC as well, and I don't know the stat for North Yorkshire and the Humber, but I do know in TESASC. So it's estimated that 1% of the population is autistic. In terms of the population that TESASC is serving, 1 in 6 patients are autistic. So that's 1 in 100 is the national average, and 1 in 6 TESASC patients are autistic. So important that we're identifying people and understanding their needs. We know that we have additional needs, additional barriers to services, and that, you know, we're more adversely affected before we have a diagnosis. We're not able to understand and meet our own needs without this additional support. Often, certainly that's my experience and the experience of many of the people that I'm working to support. Okay, if we go on to the next slide, please. Okay, so this is the kind of the beacon, the light, the place that we're really looking to move towards. So I'm such an advocate of lived experience, involvement and leadership. This is absolutely the good practice that I'm focusing on in this talk, because without that lived experience, I think it's very, very difficult. You know, people talk about autism, but without that lived experience, identification and empathy, actually it's very, very difficult for neurotypical people. You know, we can teach, we can support, but actually it makes such a difference to have lived experience involvement. Really aligns with trauma-informed approaches. Autism-informed approaches and trauma-informed approaches go so well together. There are some additional considerations, particularly for sensory processing, particularly for social processing, and I haven't spoken a lot about that, but it's a really, really significant one. I encourage all of us to be strengths-based, to be neurodivergent affirming, and to value difference rather than to focus on deficit or impairment. Absolutely to be human rights based and to understand and support regulation. And this is, yeah, it's so critical. I would really encourage us to use an understanding and a model based in Stephen Porges' polyvagal theory of understanding and supporting regulation. Though his theory, I have to say, is quite it's not neurodivergent affirming, but I don't have time to talk about that now. And finally, to be relational. So relationships are really important. The sense of safety is really important, and many of us need support to move out of our minds and back into our bodies. Again, I don't have time to talk about that, but there is more information on all of this on our website if that's of interest to any of you. And I have 30 seconds for my last slide, please. Lovely. Okay, so some suggestions and takeaways for you. Often I get calls from teams who are working with a person in crisis and they don't know what to do. And my first suggestion is, can you turn out the lights? Any small changes you can make to reduce input from the sensory environment is really helpful. Accommodations like caps, noise cancelling headphones, those kind of things, increase predictability. Really, really helpful. Consider the social environment. Again, the most unpredictable thing in any environment is people. Focus on understanding and support regulation. Clear and accurate communication. Is it going to be 2 minutes or is it going to be 5 minutes? Like, tell us what you mean and honour that and acknowledge when it isn't met. Yeah, support relational safety. Building of relationships often takes longer for us. Support embodiment. Help us to understand what is happening in our bodies and what we're feeling. And please integrate this learning into care planning. It really makes a difference. I'll leave it there. Thank you.
Jill, thank you very much for that. There's quite a lot of comments coming into the chat, but we've got some time later on to, I guess, come back to some of this. So please keep your comments coming through. We're collecting them and monitoring as they're coming through, and we will put them to our panel. So we'll move on then to Lindsay and Anne-Marie. So welcome to Lindsay and Anne-Marie. They work as senior key workers in the Humber North Yorkshire Key Worker Service. So I'll hand directly over to them for them to take us through their talk. Thank you.
Thank you. And good morning, everybody. My name's Lindsay Webster and I'm a senior key worker within the Humber and North Yorkshire Key Worker Service. I have a particular focus within the York and North Yorkshire SPERC. My colleague presenting with me today will introduce herself later. We're here to talk to you about the new and innovative Humber and North Yorkshire Key Worker Service and the key developments we are making towards achieving our service priorities for 2023-2024. We're a small dedicated team of non-clinical professionals who support the transforming care agenda so that the people within our service can get the right care at the right time within their local area. We do this through our alignment with the local dynamic support registers that hold the local area record of children, young people and adults with a diagnosis of autism, learning disability or both, who are either within inpatient settings or who may be at risk themselves of becoming an inpatient. Next slide, please. And the next slide, please. The Key Worker Service is part of the NHS long-term plan, which states by 2023-24, children, young people with a diagnosis of learning disability, autism or both will be allocated a key worker. Initially, when developing the Key Worker Service in Humber and North Yorkshire, our focus was on those under 18. However, NHS England confirmed in 2022, in line with the Children and Families Act, that they wanted all sites to be able to extend their offer to the ages of 18 to 25-year-olds. So to further develop our offer, we are working alongside Matthews Hub to think about how key workers can support those approaching 18 and up to 25 as they prepare for adulthood. The National Key Working Programme was developed through extensive consultation with NHS England with experts by experience, working with the national network of parent carer forums and other stakeholders. Locally for Humber and North Yorkshire, a project group of people with lived experience and representatives from the parent carer forums and young people's participation groups developed an expression of interest which was put forward to NHS England by Humber and North Yorkshire Care Partnership, and it was successful and we were able to secure funding to be an early adopter site for the key working function. It was a work of this project group that defined the scopes and outcomes of the key worker service, and it was based upon what mattered to families and young people from their direct experiences. Together they produced key components to build the perfect key worker. They wanted a professional who would spend dedicated time with them, listening to them, taking time to learn their language and help them to think and make decisions about their own health, care and education. Someone with excellent personal qualities who was kind, empathetic and patient with them. Nationally, the Council for Disabled Children produced guidance on key working, which identified a range of competencies key workers should be able to provide, such as effective communication, offering challenge and influence to the systems, building strong relationships, having a good knowledge of laws, rights and systems, and implementing personalisation for people and their families. As senior key workers, developing the perfect key worker is our ambition, and we strive towards achieving this through a value base where we model good communication, empathy and compassion with all the people we work alongside. Over to Anne-Marie, please, and it's the next slide.
Hello, I'm Anne-Marie Marion. I'm the Senior Key Worker within the Humber and North Yorkshire Key Worker Service with a focus on the Humber SPERC. The Humber and North Yorkshire Key Worker Service was launched in March 2022, and as you can see on the slide, it covers a large geographical area: North Yorkshire, York, Hull, East Riding, North Lincolnshire and North East Lincolnshire. So to tell a bit more about how we deliver this service, we cover the area through a hub and spoke model. The hub is a virtual control room for operations and the two spokes: Humber Spoke, which covers Hull, East Riding, North Links and North East Lincolnshire, and the North Yorkshire and York Spoke. The service was developed during COVID restrictions with the project work undertaken online. So this way of working has become integral in the development of the hub and spoke model of the delivery. This accommodates the challenges of working across this geography by developing specialist practice, providing a dynamic hybrid way of working that manages capacity but looks at delivering an equitable model based on need. So presently, within each of these spokes, there is one lead key worker and 4 key workers. So the spokes reach down within these local areas where the key workers have built relationships to understand the processes and the provisions alongside the needs of these communities. The key workers provide additional support to people identified on the dynamic support registers and the networks around them to try to ensure that their needs are met and unnecessary admissions to mental health hospital are avoided. So we continue to build an understanding of the inpatient settings within our geography, along with continuing to build those relationships with these settings alongside our work within communities to support discharge alongside reasonable adjustments for people. Next slide, please. So as an early adopter for the National Key Worker Programme, we contribute to learning on a local, regional and national level through compiling and sharing progress, reports and learning in a variety of forums and reporting. So the following 3 slides we're going to show you show the data based on our service yearly report, of which covered our first full year up until March this year. We thought it would be helpful to tell you about some of the key data and themes that we've gathered within our service based on specific needs. We know that national data tells us that autistic people can be at high risk of admission into mental health inpatient settings. So the percentages on this slide show the number of autistic people and the people with a learning disability who are allocated a key worker as a percentage of the total number who are allocated a key worker at the end of March 2023. The proportion of autistic people is relevant because if we're comparing this to Assuring Transformation data from January of this year, we can see that the inpatient numbers nationally for those autistic people are now significantly higher than they are for those with a learning disability or with both diagnoses. The data has also showed us that we are supporting more males than females, and we are considering this against national trends and themes. But as a service, we do know people present with a wide range of needs, so it's really important for us to consider gender, consider identity when thinking about people's unique needs and thinking holistically rather than through a single lens. So can we move on to the next slide, please? Thank you. So our approach is to adopt a social model of disability to understand people's needs and rights and to work alongside them to help remove challenges by navigating processes. We know this can be really difficult and unmet need can arise when there are gaps in provision. So we need to listen to the person, listen to the network about any blocks or challenges experienced. And by working for people with services in local areas, we seek to make sure that support is coordinated and streamlined to better meet people's needs and therefore reduce risk. So to provide some context to this, there are often a number of processes and people involved and different approaches and different local responses. So this slide shows the percentage of children and young people allocated a key worker and their social care legal status up until March of this year. And you can see there's a high proportion of those within the service who come under the Child in Need framework, therefore have social care support. The NHS long-term plan commitment identified a role for the key worker function for those with multiple vulnerabilities, which includes looked after and adopted people. So the slide also shows a number of people allocated a key worker who were looked after by the local authority or adopted to show how we are progressing as a service. So next slide, please. As mentioned earlier, the Key Worker Service is working towards extending the reach of this service up to 25 years old, and that's in aligning the key worker function with the intention of the Children's and Families Act. The Children's and Families Act provides the legal context around identifying, assessing and provision of special educational needs as part of a graduated approach. So in this slide, the data shows the number of people registered within our service who have an education, health and care plan, and of those, the number that have a personal budget as part of this. So this is shown as a percentage of the total people who are allocated a key worker by the end of March this year. And as you can see, over 3/4 of those being supported by key worker did have an educational health and care plan, and 4 of these were in receipt of a personal budget. So nationally, it has been identified that key workers do need to focus on access to personal budgets. And within our project group, when developing the key worker service, it was highlighted that people do not always experience support and provision that is personalised for a number of different reasons. So we have worked and we are working with experts by experience and peer leaders to develop the idea of a designated role within the key worker service, and that's to ensure that personalisation is embedded across our service. So we are pleased to share that we have now appointed a personalisation coordinator who is working with the key workers to further develop those personalised approaches. So this includes understanding individual needs, qualities alongside interests, how these can be used in support planning, considering how people are involved in decision making to empower and enable choice. And we seek to consider people's preferences in how they may like to receive information to enable that effective communication and for their wishes and feelings to be considered when thinking about meeting their needs along with decision making. So we hope to promote individual strengths by utilising assets and resources in the community alongside sharing information to bring clarity around the statutory processes for personal budgets. And we have found that of those allocated a key worker, people may have been able to verbally express their wishes and feelings about their support and their aspirations, but key workers will continue to work to ensure that reasonable adjustments are made to further support and promote this, and we will be providing some examples later. So I'd now like to hand you back to Lindsay, and the next slide, please.
Thanks, Anne-Marie. The next slide, please. So this is about our priorities. So as we mentioned, we are an early adopter site for NHS England, and we continue to test, learn and evolve. In our recent annual report, we shared our priorities for this year. So I'm just going to pick out a few of them for a bit more information. So priority 3, we know that for young people and their families at times of crisis, they may have lost trust and experienced trauma. For those that are working in the systems around people, sometimes situations can become fraught and fragmented. So as a service, we work to understand this and understand their misunderstandings. We've worked to embed the AMBIT framework to support the key workers in developing the change function, which I'll describe later on in the presentation. AMBIT means Adaptive Mentalisation Based Integrated Treatment, and it was developed at the Anna Freud Centre. In this next year, we want to continue to share helpful ways of working when there are several teams involved supporting a person, and how together we can all really focus on the person's perspective, encouraging people in the networks to support each other in their roles and not to become isolated in practice, to make a change to improve outcomes for people and their families. One way we hope to do this was at our first conference in October, and it was a real celebration of the service's journey to date, and it was co-chaired by a young person with lived experience who shared his experiences of key working and how this had really benefited him. Priority 5, the key worker service was designed by experts of experience, and they told us about the value of peer support as a supportive measure to be non-judgmental, sharing understanding, experiences and validating feelings. To respond to this and to think about how we could reach out from the key worker service wider into the communities, we've commissioned Kids, the National Disabled Children's Charity, to work with us to look at how a community of experience could offer this support. Priority 6. As we mentioned, we work across the local systems and we work with those with multiple needs that may need risk support, as identified by the Dynamic Support Register. And you'd seen from our slides earlier that we're beginning to collect that data and information on themes and trends that could provide learning and understanding and will be helpful to the local area in their responses to the emerging needs of children and young people to ultimately enable better outcomes for people. The last priority I'll mention is priority 9, and that's the provision of the key working function, which identified it's a responsibility of the integrated care system, and we are a service that's provided on behalf of the Humber and North Yorkshire Healthcare Partnership, who are hosted by Humber Teaching NHS Foundation Trust. We initially developed from within the provider collaborative, which enabled us to build understanding and links around the pathways and inpatient services. This provided us with an invaluable start. However, now that we're fully operational, we've transitioned and we're being hosted by the Children and Learning Disability Division to support us to have robust processes and governance as we move forward from an early adopter development site to a fully operational service embedded across Humber and North Yorkshire. Could I have the next slide, please? So our workforce is made of people from a diverse range of backgrounds, including education, social care, health, and the voluntary sector, including those with lived experience, and they each bring their own experiences. We are positive about continuous professional development and learning from people with lived experiences to better meet people's needs. The team have undertaken the Oliver McGowan mandatory training on learning disability and autism, and key workers receive training to understand the legal context to ensure that people's rights are met with regard to the Mental Capacity Act, Autism Act, Human Rights Act and the Equality Act. Key workers strive to ensure that they practice, ask, listen, do, by putting people at the heart of decisions and making sure that their voices are being heard. As a service, we've been really fortunate to access the Anna Freud and AT Autism training. These organisations joined forces to develop the Autism Train the Trainer programme for NHS England. The course is aimed at mental health professionals and all other relevant staff, including all age inpatient mental health hospitals, community mental health settings, residentials and special schools and colleges, and health and justice settings, who currently work or may work with diagnosed or undiagnosed autistic people. The training programme itself is co-designed, co-produced and co-delivered with autistic people, and it promotes an experience-sensitive, trauma-informed approach. I was really fortunate to secure a place on this training, and I undertook it within just recently in the last few months. So I'm really looking forward to organising this delivery out to the key worker team, and I'm going to be co-delivering that alongside an expert by experience who's going to help us to continue to deepen and embed our shared understanding of people's needs. The next slide, please. So through this presentation, we have looked at what the key working function is and why this is needed. And we'd like to end by telling you more about what difference does it make. Key workers provide a function that brings a mechanism of change within local systems by making sure that people's wishes are at the heart and listening to these, unblocking any barriers and seeking to do something to help to achieve their outcomes. Within our team, we refer to it as the little things, but as we know, from small acorns, mighty oaks grow. And we'd like to share some examples with you of how we've been that mechanism of change. So key workers in the team have assisted young people and their families to have a say on their education through advising them on their rights to an education and helping them to access bespoke special education provision, either through an enhanced provision within their local mainstream school or access to alternative special education provisions or one-to-one tuition. And key workers have linked in with local schools and local authority systems to ensure that appropriate provision and funding is provided, either through the special educational needs budgets or through an education health and care plan. Now, another example is where young people have found it difficult to engage with CAMHS provisions within their area. Some young people have told their key workers that they felt unable to access CAMHS therapy that's been offered to them. So the key workers have built trusting relationships and a sound knowledge of the young person's needs, and over time have been able to influence the change in their decision to engage with CAMHS appointments, sometimes with the additional support of key workers joining those appointments. Key workers have also worked alongside professionals in the systems to expedite timely access to a range of CAMHS services, ensuring that appointments for those most in need are offered within a few weeks rather than months. I'm going to pass over to Anne-Marie now, who's going to share some further examples. Thank you.
So a key worker was able to work with a family to identify what would support the person to develop their confidence, self-esteem and socialisation skills. And they then liaise with the other professionals around that person to gather evidence to request a Section 17 social care assessment, because this had previously been turned down. And the purpose was to consider possibly a funded package of support. By the key worker gathering information on behalf of the person and the family, they were able to have an assessment agreed by social care. Following completion of this assessment, the person did meet the threshold for a package of direct payment hours. This helped to develop a bespoke plan and package in the community, and that has enabled that young person to access the community frequently, which encourages their social opportunities and their independent skills outside of the family unit. Another key worker heard how accessing health appointments was really difficult for a young person. The key worker supported them to complete the Autistic Girls Network Healthcare Passport. With the person's consent, this was then shared with all professionals to ensure that the right information was captured in a way that the young person wanted it to be. The person did have to attend A&E and they took the passport with them. They then shared back with the key worker that the health professionals at the hospital had actually looked at the passport and used it on this occasion. And they said that that had made their visit less uncomfortable than usual. And again, this supported the importance of reasonable adjustments being communicated and actioned to support someone's personalised needs. So if we could just move on to the last slide, please. So we hope you found this snapshot helpful, and for more information, please see our contact details. If you'd like a copy of our first annual report with more information on what you've heard today, please contact us. We also have a video to tell you more about key working and how we use Ambit, alongside information on our webpage, or you can find this information on your local offer. Thank you all very much for listening.
Anne-Marie, Lindsay, thank you very much for taking us through that. And again, a great number of comments coming through showing appreciation for everything that you're doing and the work that you've done so far. So thank you very much. Let's keep going. We're going to have plenty of time, I think, for some questions. We've got Jill from Matthews Hub. So let's hand over straight to Jill, hear from Jill, and then we can start to draw through some of the questions. Jill.
Thank you very much, and thank you for inviting me and Matthews Hub to present what we do. Can I have the next slide, please? And the next one, please. Okay, so Matthews Hub was set up in 2014, which is quite incredible to think that we're nearly 10 years old, and we became a charity in 2016. We support autistic people and those with ADHD without a learning disability. We at the moment cover Hull, East Riding and North Lincolnshire. As has been said before, we support people who are 13 and up, and we have members who are in their 80s. We have over 1,400 members, which is what we call the people who we work with. And what's interesting and has been sort of picked up by some of the other speakers today is that although traditionally people talk about autism being 80% male, that our membership is actually 40% female. In fact, it's a little bit higher than that at the moment. And we have quite a high percentage of transgender, particularly younger people who are questioning their gender, and also quite a high percentage of LGBTQ+, which is, makes our support more interesting and more challenging in terms of what we need to know and how we need to proceed. So next slide, please. All our staff are neurodiverse, which is interesting, challenging, wonderful, and also is sometimes, and these are their words, not mine, is a bit like herding cats. Our staff are autistic, they have ADHD, and they're dyslexic too. So we have a range, and they are multiply neurodiverse. So we have those who are autistic and have ADHD. We have people who are ADHD and are dyslexic. And they all have their lived experience alongside their qualifications and their worked experience, which means that they have that experience of looking out and looking in. And I think that that's been described several times already this morning. And I think that given the different qualifications and worked experience that our staff have, mean that we have that range of experience and skills, which means that we can support people, I think, quite adequately, and sometimes with a very different lens than some other services. So if we can have the next slide, please. So I wanted to this is something that myself and the service manager have worked quite hard on looking at, the range of neurodiversity. And I think it's really interesting that the NHS long-term plan and the NHS as a whole has chosen to focus on mental health, learning disability and autism, when actually when you look at neurodiversity and the prevalence, that actually the prevalence is significantly higher in a number of the other neurodiverse conditions. And I'm going to show you later on about the likelihood is that if you have one type of neurodiversity, you are highly likely to have another. And I think that that is something that we try and work really, really hard on when in terms of our support from Matthews Hub, is about realising that actually the people who present to us and the people who we're working with and trying to support may well have more than one neurodiverse condition. And actually what we are seeing and how we need to be supporting them needs to be understanding of that. The reason that we started off, we became a charity because Matthew's mum came to the charity that I was working at previously because Matthew died by suicide in his early 20s. And Simona, his mum, believed that had Matthew had the appropriate support, he wouldn't be dead. And she also, Matthew has a twin, Sam, and Simona was very scared that Matthew would die, that Sam would die in a similar way. And so I'm very mindful all of the time about that, as why, you know, our reason for being and our reason for being set up is that risk of suicide, which is actually very high and higher significantly in most of the neurodiverse conditions. So I think this is just useful just to show that probably at least 20% of the population is neurodiverse, and the presentations that people bring with them to appointments within the NHS and other statutory sector organisations. It's about understanding that probably at least 1 in 5 people will need to have a different approach. And I think that Jill Corbyn's description about that was really, really helpful for me. Can we have the next slide, please? So this is pinched from somebody who I have to say I'm a little bit obsessed with, and this is Professor Amanda Kirby. And I think that she's a medic, she is neurodiverse, she has a number of people within her family who are also neurodiverse, and there is something that she, alongside others, has created, which is the Do It Profiler, and part of the research that was done for the Do It Profiler looked at co-occurrence and comorbidity. And you can see here that if you have a primary diagnosis of autism, that you are up to 80% likely to have ADHD as well. Hence why when although we started off as supporting only people who were autistic without a learning disability, we added in ADHD, partly because there was no other service that was supporting people with ADHD, but also because of that co-occurrence and the need to look at both of those neurodiverse conditions. And although some people say that ADHD is a new thing and it's, you know, it's something that, you know, even some people have said it doesn't really exist, actually ADHD was first described in 1775 by Adam Whitehead. And so it's something that's been around for a while, in fact, longer than autism, given that autism was first described in the 1940s, as we know. So the reason that we that we added in ADHD is I think is quite important. If we can have the next slide, please. So in terms of what we do, we work very closely alongside our local mental health trust to provide pre and post diagnostic support, and that's very much about the psychosocial interventions that the NICE guidance describes, and we have developed a really very trusting relationship with the assessment team. We do not provide the assessments. Ours is the before and after support. And before diagnosis, we support people to really, we manage expectations about what if you're not, what if you don't receive a diagnosis, because that's really important, and also about what the process will be. And alongside some of the other comments that have been made this morning, it is really important for people to have a diagnosis, and it does make a difference for people to have that acknowledgement of what they are experiencing, what they have inside them and their experience of the world, to understand why. And that is something that does make a difference for people, and those that we support, it does matter to them that they know. And the bit about, well, we don't want a label, actually it's not about a label, it's about an understanding. So I think that's something that is really important. And post-diagnosis, we work very much with people to understand how their autism and or their ADHD is experienced by them, what it is that we can help them to develop reasonable adjustments, how they can develop support mechanisms for themselves, and what works for them. And quite understandably, everybody's different. And as Jill described, you know, that bit about the sensory issues are huge, and something as easy as turning off a light can actually make a massive difference. One of our staff, who is an amazing guy, who wasn't diagnosed until he was in his middle 50s. He's a qualified teacher. He's worked for Samaritans. He's been a traveller. He's had an amazing life. But he also has a master's in autism. So all that lived experience plus a master's means there's not much he doesn't know about being autistic or what it feels like. He talks about autism plus environment equals outcome. And I think that if he was here, that's what Carl would want me to say. And again, autism plus environment equals outcome. And the other thing that he talks about very much is about, he is not a broken, non-autistic person. He doesn't want fixing. He wants things to be reasonable adjustments, which help him as an autistic person. He doesn't want to be fixed, and I think that's always really important too. So we also provide peer mentorship, and what that means is that our staff who have their lived experience support people who are autistic and or have ADHD to better understand themselves. And that peer mentorship might be about housing, it might be about employment, it might be about relationships, it might be about a range of just life. How do I live my best life? Equally, it could be housing, and we do provide some housing related support, which is very well received. So all of our service is created and developed by autistic people, as well as being delivered by autistic people. So I think that means that hopefully we understand the needs of people, although we do not get it right all the time. And we very often have to go, that really didn't go very well. Let's look at how do we improve that. We've started supporting schools, and I think we originally started at 16 and up, and then it became really obvious that actually, because of transitions and because of the needs of younger people, that actually we dropped our age to 13, and that's been really helpful. And we're working in secondary schools now, providing group meetings on a monthly basis, that any of the young people who think that they are or have a diagnosis of neurodiversity, and particularly autism and ADHD, can come and talk about their experience and what support they need, what reasonable adjustments they might have, and need, and then we talk to the staff about that. One of our staff is an RMN, and she has ADHD and is dyslexic, and she provides the emotional wellbeing support on our behalf, and links very much with the Humber mental health teams, and that relationship has worked really well. We've had our second big lottery grant, which has allowed us to continue the social and advocacy opportunities that we've been delivering since we started, and that really means that we can have spaces where autistic people can come and just be where they, in their words, they find their tribe, they can just be themselves, and we've started after lockdown, after COVID, we've started actually using local pubs who are struggling because of the energy bills and those sorts of things. So we've been using those spaces in the communities, and that's been going really well. And it normalises, the meeting. It's not an autism ghetto, and again, that's their words, not mine. We do a lot of training and awareness raising, both in terms of awareness raising for autistic people about what is affected by their autism and what is just life that everybody, autistic and non-autistic, experiences. And those workshops have been, again, written, developed and delivered by autistic people. So there is that lived experience, and hopefully what we try our best to deliver is the right support to the right people. I've often talked about my background is NHS, and for me, we contribute to clinical governance in that we can provide the support at the level that we do, but equally can then allow the experts within the NHS to work at the level that they should be working, and working together, I think, it means that the right person sees the right person at the right time. Support for parents has been really important, and it's been something that we've been doing more and more of. Because many parents are actually undiagnosed, and as their young people are diagnosed, they look and say, actually, that might be me too. And so there is some level of self-awareness, but also about how they may best parent and best support their offspring. And I think that bit about understanding our own neurodivergence is really important, because that helps us to see the world from the point of view of those who we are trying to support, which I think is very important. Next slide, please. So thank you for listening, and I'm really pleased to have been here as part of this really important conference. Those are our contact details, and I look forward to hearing from people at a later stage. Thank you.
Jill, thank you very much for that. And can I thank all of our speakers in this section. Certainly thank you for being very good on your timekeeping, which helps, because that gives us 15 minutes or so for some questions. There's been, lots of contributions as you've all been speaking this morning. And a lot of appreciation for what you've said, and certainly for what you do at Matthews Hub and within the Key Worker Project. So again, just to acknowledge that and to thank you for everything that you're doing. So look, so that there are some themes that have been emerging as we've been sort of scrolling through the conversations that are going on online there. I'm sure I'm not going to be able to do all justice to all of them as we go through, but I wonder if we could just start off with one about I suppose, the comorbidity point that Jill Paul was making, and I think Jill Corbin touched on it, this kind of interface really with trauma, and how that affects the emotional aspects and and interfaces with autism. Jill, if we could turn to Jill Corbin, I guess just in terms of your perspective on this and how we can be, I guess, better at sort of bringing in a better understanding around that interface, that comorbidity into what we do. What's been your experience in your conversations and the work that you've been doing?
Thanks, Brent. Well, I guess as with all of our work, we need a good baseline understanding of what people's experience might be. People might experience different kinds of trauma, but my experience in this work is that our sensory trauma is often not understood. And so for me, a definite starting point is to have a really good autism-informed, neurodivergent affirming understanding that enables and facilitates individual conversations. Everybody is different, everybody has different needs, everybody has different experiences. And what I see is that people feel confident to have those conversations and to explore that with people and to explore people's experience and needs when they have that really solid kind of background understanding. It really supports individual conversations. So for me to be able to divulge my experience and my needs, even as an autistic professional, it's still really hard. It's really hard to ask people for support. It's really hard to ask for our needs to be met. It's really hard to ask for adjustments. But to work with people who know me, who understand me, who I've established a relationship and trust with, that really supports me to divulge. And often what we see is that this is established in small steps. So what I often do is I share a little bit, and I see if I'm met and I'm seen and I'm heard, and if I'm not, I'm very unlikely to share the big stuff. And I think Jill at Matthews Hub spoke to this, like, or maybe it was other colleagues, like it is in those small moments, it is in those things that you might think this doesn't even matter, but those small steps really build the trusting relationships that enable the big and important conversations to take place.
No, thank you very much for that. I wonder if I can turn to Jill Paul, just I guess to pick up that thread and just maybe expand a little bit on what you were saying.
Sorry, can you just say that again? I just lost it. Sorry.
No. Well, obviously we were talking about, I guess trauma as a theme, and Jill was talking about, I guess, some of her experiences around how she engages with people in terms of, I suppose, disclosing information and building that rapport, that relational aspect to what happens. But clearly, when you presented your comorbidity grid, I think the colleagues online were reflecting, I guess, is there an opportunity to maybe be a bit more explicit about that linkage with trauma?
Absolutely, and but without a doubt, and I think it needs to be the same approach, and I think that Jill really said that very, very well in your presentation, that it needs to be the same approach, because very often people don't know when to disclose, they don't know how much to disclose, and also if they have that comorbidity, that co-occurrence, it's about, do I disclose all of this, or do I, and also it's about, sometimes we had a very interesting conversation with one of our members of staff recently. She's so articulate and so clever. She's autistic and she has ADHD, and when she was medicated for her ADHD, she actually found that her some of the symptoms that she experienced from her autism actually were heightened, because being autistic and having ADHD, that the ADHD actually sort of mitigated against some of the autistic traits that she experiences, and then she felt worse actually, because and it's things like that that I think prove just how much this needs to be an individual and a very, very person-centered approach. It is not one size fits all. But I think it's the little things for this woman. It's about communication being so clear and so concise. That helps her enormously, because if she has that information, it really, really helps. And I think one of the biggest things that I've learned over the years, and I get it wrong daily, is communication, and about making that as clear, concise, and as exactly what I'm not doing at the minute. But yeah.
No, you're doing great. Thank you for that. Just moving on to another question. I mean, we're hearing obviously a lot, aren't we, about personalisation, communication, but also I think another key thing is about the impact of lived experience voice in this. I'm wondering, turning to maybe Anne-Marie, in terms of the Key Worker project, whether you could say something about the role of parents and carers. There's quite a number of parents, I think, quite active in the chat on here, and I suppose just say a little bit about parent and carer voice in the work that you've been doing in the Key Worker project.
Hi Brent, it's Catherine. I wondered if you'd like me to pick this up.
Yeah,
just
by
to
all
give
means,
you a
Catherine.
little bit. Just to give you a little bit of context, so when nationally the Key Worker programme was launched, it was developed with the National Parent Carer Forum, which put an expectation in the early work about making sure that you link to the parent carer forums in your area. However, that's not the only people that we link to, and we do try and link out further and make sure that we speak to other groups. So we work alongside our partners in the voluntary sector, such as Matthew's Hub. We've worked alongside kids that have supported along with their young people's participation groups, and we continue to share information through local forums such as Sendias, the local offer. We've worked to develop the community of experience, which is based within kids, who will go out across the 6 areas and share information with different community groups and parents groups, and we try and make sure that that message is shared across so that parents are aware of the support, they're aware of how you can find information, but also aware of the dynamic support register. And what we find when we receive referrals to the service, that sometimes we might be working with the child and young person or young adult themselves. Sometimes it might be the family that are around them, depending on that person's situation at the time. Sometimes it might be thinking about how the network can better support people. So it's really based on what individual people and their families need from us at that time.
Thank you for that, Catherine. Appreciate that. Just on this theme of lived experience, coming to Jill Corbyn. I mean, you acknowledged as a professional working in this area, it can be quite hard for you to talk and advocate for yourself. But what if you could just say a little bit about how we can maybe open up really more to the voice of lived experience, enable that, and I guess put the right support in for people to engage in that way. Could you just give us a little bit on your thoughts on that?
Thanks, Brent. Yeah, it's a big question. I suppose similar to my answer to the last question. I think it comes in lots of small ways. I don't think it's, you know, there isn't a thing we can do that will fix this, but often I'm speaking to teams and autistic colleagues, autistic members of staff come and disclose to me and say, and I haven't felt safe to disclose in my workplace. So definitely there is need for cultural change and understanding. I think when we shift our language, when we move away from talking about disorder, and when we stop talking about people as being challenging or complex, and we start talking about systems as being challenging and systems as being complex, people feel much safer to identify themselves and to bring those additional assets and insights that they can share with their teams. I think a generic but neurodivergent informed training across workforce can support that. Additional ways that we can support this, we can employ lived experience roles whose focus is on lived experience. We can value those people and those roles as integral parts of our teams, and we can have really good quality engagement mechanisms that pay and recognise people for their time and contribution. It worries me when we talk about co-production, but we don't recognise the time and contribution that people bring to improving services and supporting our work. Yeah,
that's really great. Thank you. And just turning to Jill Paul, I suppose your organisation, the team that you explained, obviously is a living embodiment, isn't it, really, of people with lived experience working in this area. I guess in terms of supporting people out in the community that come and work with you to, I guess, get involved in some of this sort of work. Have you got any thoughts on how we might do that better?
I totally agree with what Jill said. Actually, I think that that valuing and is really important, because and we have, for example, in the autism strategic partnerships within each local authority, there is autistic people attend those, and that's all about the local strategy for autistic people in those areas. And they're expected to attend, but they're not paid. They're the only people who aren't paid. And actually Matthews Hub pays locally, because I think it's so important. I think it's just wrong. Controversially, I don't like the term co-production, because I think that it actually often isn't, and it should actually be led by autistic people, and with non-autistic people supporting them to do it best. So I think I almost come from the other end now, where all of our stuff is what our staff and our members want, and then we think about, well, how are we going to do that? And there are some things where we actually say, well, actually no, that's not possible, but explain why. So I think it's almost coming from the other end, which is hard. It is really hard.
Absolutely. Okay, thank you for that. Just changing tacks slightly, there's been some comments in the chat about inequalities. I guess just how perhaps for white middle class people with a few quid, actually it's easier to perhaps navigate the system than it is for perhaps others. I mean, just your thought, I guess, in terms of that. And as there are so many barriers, aren't there? There are so many issues that we've highlighted through our conversations this morning. We're a very diverse region that we work in here, but we need to make sure that we are in a position where we, I guess, neutralise some of those barriers and work through some of those challenges. I guess in terms of your experience coming to Jill Corbin first, just thinking about, I suppose, some of those underlying issues and how we might, as a system, respond to that specifically. I think it's obviously something at the front of colleagues' minds this morning.
Thanks. Yeah, it's interesting, isn't it, Brent, that we're a diverse system, but I look at our speakers, and I don't see that represented, and I think we have to shift our thinking and really make effort to be representative and to share platforms and to support people to have profile and generate income and generate work. And one of the ways that we've done that in my organisation, and so we've been established for under 2 years. We're a small community interest company. We established by delivering projects at no cost, so that we could at low cost, so we could set up. And we have been advertising neurodivergent friendly recruitment practices. We've been shifting how we work. We've been enabling people to job carve. We've been actively trying to recruit people of colour. We've just set up a Black and Autistic peer group that is led by someone who's Black and Autistic, who are able to pay for their time. So I think, again, it's in small ways, it's in small changes, but we need to be making effort, and we needed to be making a commitment and meeting that commitment to recognise and support people who experience different intersectionality, and including queer. I'm a lot of my organisation are also queer, and that brings its own challenges. I use they them pronouns, and it can be really challenging. At what point do I say, actually, I'm not she her? When do I challenge that? So but I think often this begins with this conversation, with asking this question, with inviting the challenge but responding to it, because if we don't respond to it in an affirming way, then people will stop telling us, they will disengage. So it's really, really important that we show that leadership, but also that we're putting time and funds into it to support this to be realised.
Thank you very much. Just on the same theme, coming to Catherine, in terms of the key worker project, I'm just wondering how much time the key workers spend, I guess, supporting people, through some of these structural inequalities to navigate the system. Is it something you could offer really in terms of, I guess, some insight into that and how that feels?
Yeah,
Catherine.
I think people can face inequalities for a range of reasons in accessing services and the support that they need, or barriers to reaching out to that. And I think Jill's given us some interesting examples there about how organisations can present in a variety of ways that may make people think that they're either welcoming or not welcoming, and how we can all continue to do more to try and reach out to communities and reach out to people wider to try and make sure that they are aware of services and that they know how to access them and that they feel welcomed when they receive those services. I think some of the things that we do see in the key worker services, often people when they are at that point of crisis, they've had a long journey of trauma that can be really difficult, and some of that trauma has often occurred because they've not had the right kind of help at the right time for whatever barriers or challenges that there were there. And sometimes it's about our main focus is sitting alongside them and hearing about those barriers and challenges, and going back to sometimes look at how we can influence and try and remove some of those barriers that systems sometimes inadvertently put there. Sometimes, as we said, we use ambit in our practice, and sometimes we have to understand some of the misunderstandings. Sometimes we have to make people aware of reasonable adjustments, and sometimes we need to maybe think how things can be done differently or delivered differently. So that's often the work of the key workers, and one of the things we'd like to do in this year as we focus more on personalisation is start to think about some of the themes and trends we're finding, so we can share that back from people with lived experience back to the system and try and learn more. And that role was developed using peer leaders that have already kind of been experienced within the system themselves and have learned to try and work with us to better improve that service and access.
Thank you so much. Thank you, everybody. That's the end of this session. So can I just say a big thank you to Jill, to Catherine, to Anne-Marie and to Lindsay for your contributions in this session. It's been a really interesting and engaging session. And again, there's a lot of love in the chat for everything that you've been saying in this. I'm going to hand over the chair now of this conference to Michelle Moran. I want to thank everybody for their contribution so far this morning, including those of you that have been contributing ferociously to the chat, which has been great to see. There are a number of key themes that are coming through for us as a collaborative to think about, whether that be about communication, about how we are more relational in what we do, focus on personalisation, being more responsive, thinking about how we are seeing and recognising and engaging with barriers, and thinking about how we can be better focused on people's needs. Haven't touched on any of the comments there about the environment and some of those adjustments that we can make, and so on as well. So plenty of food for thought. So let's continue that into the next session. Michelle will be hosting the next round of speakers coming from a national perspective, and I hope that you all have a good rest of conference. And I thank you again. Thanks now. I think we're due back now at 12:05. So if you could come back promptly, then I'm sure that Michelle will do her best to get things concluded by 1 o'clock to get you on with the rest of your day. So thank you very much.
doing, Claire Murdoch?
I'm fabulous, thank you, Mr. Tom. How are you doing?
I'm very good. I'm very good, thank you. Good to see you.
It sounds like it's been a really great day so far.
I was in the early part of it, and yeah, really good start. Really good start to it. It's really compact, I think. Good luck.
Wonderful. Are people on a coffee break?
I assume so. I think it's resuming in 5 minutes, so
Lovely.
I'll go quiet and leave you to yourself now. And
I'll just finish making my last couple of notes.
I'm on straight up.
Well, welcome back. Good afternoon, everybody. My name's Michelle Moran. I think I briefly introduced myself earlier on today. What a fantastic session this morning, talking about everything to do with autism. There's some great presentations from our showcase presenters. And it gives me great pleasure to introduce the second part of our session this afternoon, which is around the national picture. So we set the local context, which I think is really important, and really looked at some of the work that we're doing in Humber and North Yorkshire, but also within the chat box, what's happening wider. And it's great to see that communication in the chat box as well between you. So please keep that coming for the next session. So we're going to start with a mental health overview for the next about 15 minutes or so from Claire Murdoch, and then we're going to go on to Tom, who's the National Learning Disability and Autism Director. So I'll come on to Claire first. So good afternoon, Claire, and welcome. Claire doesn't need any introduction. I'm sure you all know Claire really well. Claire is our absolutely fantastic National Mental Health Director who really champions mental health and autism. I know Tom's got the mantle on that, but really champions it through all the national and local and regional teams. So good afternoon, Claire. Over to you, and welcome again to our 5th conference. This is the 5th conference, if you can believe it. Claire has been with us all the way through, so seen us grow and develop. So it's fantastic to see you again, Claire. So good afternoon, and over to you.
Michelle, thank you so much for that hugely positive and upbeat introduction. I'm really grateful. And I just want to pay huge tribute to you and other colleagues who are making this conference happen year on year, come rain, come shine. And I think it is an absolutely important opportunity to stand back and reflect together on progress made and where next. And I'm also really glad, if I might say, Michelle, that you mentioned the partnership with Tom and thinking increasingly together, which Tom and I do with colleagues across the system, such as yourself and others, about where there are interfaces across autism or learning disability and mental health, and trying to make sure that we're constantly thinking about the services we provide in mental health to make sure they are flexed to and appropriate for the needs of individuals. So, you know, thanks for mentioning that. Can we just put I'm thinking someone's driving my slides. It would be wonderful if somebody, look at this, the next slide then, please. This is just a one to show actually we've come a long way since 1954 and indeed before that. And I was forced to reflect, having just realised 2 weeks ago, on the 23rd of October, so slightly more than 2 weeks ago, it was my 40th year in the NHS, and I began in 1983 when the then Mental Health Act was new and everyone was talking about how much we'd all have to learn and do seminars, and it was a much more rights-based act than the one before it, the Mental Health Act before it. I do just want to note here that there is a lot of disappointment about the fact that we were expecting the King's speech to announce another new Mental Health Act 40 years later. But it wasn't in the King's speech this week. And I know from the point of view of people with learning disability and autism, as well as mental health, that was a feature, and Tom may pick up on that more. Just to say, from my point of view and the point of view of my team, this is a blip, a bump in the road. This is not over, and I'm very much, you know, looking forward to working with government and other policymakers on making sure we do get a new act. I want to fast forward us though to, obviously we began in 2016, as colleagues will know, looking at the 5-year forward view for mental health. And that was going to be 5 years. But what then happened was the entire NHS moved to wanting the long-term plan, which was also a 5-year plan. So we put the 5-year forward view and the long-term plan together, and that created 8 years of additional investment and improvement. We're just coming to the end of the 5 years of the long-term plan. I think it will be very familiar to people that the plan was to get 2 billion more invested by 23-24 by the end of this year in mental health services. We spend about 13 billion a year, so that on mental health services across the country. So it gives colleagues a sort of a bit of an idea of percentage and quantum. But can we come on to the next slide, please? We know that between sort of 2019 and the 2 or 3 years that followed, we had the shockwave of the pandemic, you know, across the world and the country, and we know that affected our services. Also, it affected our service users. So we were trying to lean into, as we know, a sort of pre-existing treatment gap in mental health. I would say, you would all say, a totally unacceptable pre-existing treatment gap in mental health. And up here is a slide that shows some of the progress we've made, but it would be wrong to look at this, which I'm about to in a moment, without acknowledging that we've seen an increase in a demand linked to the pandemic, and particularly in certain services, whether that's eating disorder services or disordered eating, or a link between those services and autism and neurodevelopmental disorders. And some other services, we've seen big spikes in demand, so including crisis and emergency services. So I think that for many of our service users, as we've got through the very worst of the pandemic, we are seeing our spike in demand and our kind of shockwave following after. And huge thanks to colleagues across the country who are working just so hard to make sure that despite all of that disruption and the tough times that we're confronted with in the world currently, whether that's the wars, war-torn countries, some of the horrible news there, the economy and people really with the cost of living struggling. Despite all of this, this is a sector, and I don't just mean the NHS, I mean our partners in local government, third sector, our patient partners or lived experience partners. We are all really going for this. Part of my job is to make sure that we go for it as well over the next 5 years too. Huge backing from Julian and Amanda at NHS England. They know that we're on a journey and we need to continue it. But I want to note all of our partners. This slide, I've left it up for a while because I don't intend to go for it all, but I'm hoping that colleagues and people on the conference are really looking at some of the things that we've been doing despite all of what I've just described and some of those achievements. About 14% of the country had specialist perinatal services when we began this journey. Now they exist everywhere. Similarly, more people than ever accessing talking therapies. More children and young people than ever before, a record 720,000 currently accessing services. And during the pandemic, we rolled out our first mental health support teams in schools, and we're going to smash the target we set ourselves in terms of national rollout and coverage. We were aiming by the end of this year to be at 25% of schools and colleges having mental health support teams. Actually, I'm hoping by the end of next year we'll be at 40%, and then we need to see where government funding and the next 5-year plan sits. I would just say about those mental health support teams in schools that they're about prevention, education, partnership working with parents, youngsters and educationalists and primary care, whoever's in that local system. They really are an opportunity to think differently, intervene earlier, to try and, for example, spot autistic youngsters earlier. We know that there still is an issue of them turning up, and Tom will talk about this, in inpatient services and being diagnosed or identified for the first time then. So these mental health support teams in schools, we hope, will be very much part of across a whole range of conditions for young people, acting sooner as well. I think it's remarkable. We think we're the only country in the world that's doing something like this, and we should all be really, really proud. In terms of our first advancing mental health equality strategy, which again we published during COVID, October 2020, and we wondered, should we publish it during COVID, given that the NHS was really only letting totally life and limb business critical policy go out the door. Guess what? We thought this was life and limb business critical policy, knowing what we know about the differentials for certain patient groups, not least of all the premature mortality, the different experiences of racialised communities. And a couple of weeks ago, I was really proud to launch formally the PCREF that I know you're all looking at, and thanks to Jackie Dyer and colleagues for working with us on that. And I would just say, look, we're going to need to move on, but I would just say we've also grown the workforce by more than 30,000 staff during this period. 30,000 people working in mental health who weren't a few years ago. I think that's extraordinary, and I want to acknowledge that workforce still remains one of our biggest challenges and worries. Of course, it's also a colossal opportunity in terms of changing culture, challenging things like compassion, and are we really working in different ways with people we serve? Now, of those 30,000, many will have been peer support workers, apprentices, therapists trained through universities in our mental health support teams in schools. I think we're at about 2,500 trained therapists who spend a year, as you all know, earning and learning, half in service, half at university, and come out at the end of that year able to be supervised and supported therapists in our mental health support teams, IAP services. We're rolling out similar roles in our community transformation area as well. And you've heard me talk before, I think, about the all age crisis lines, you know, which went from nearly nowhere in the country to the whole country during the pandemic. Now, with all of these services and achievements, and I'm also really proud, by the way, of, I think we're at maybe 52 NHS-led provider collaboratives now, so they're growing all of the time. But with all of these services, I do just want to note that we know there is this constant job of localising them, really working with local communities at place. It's one of the great strengths of the ICSs if they really deliver on their promise. And by promise, I don't mean promises they've made. I mean the promise that having a community facing local set of commissioning and delivery, and all of us working together, could deliver around whole population health. And, you know, our desire to stop siloing physical and mental health, for example, where often people have both. And wouldn't it be nice if we could redesign care around that? But I am aware we have to do more in the equalities space. So bravo. Can we go on to the next slide? Because I know I need to stop quite soon. This is just a slide that shows that we're well on track to deliver on the promise of the investment flowing. By 23-24, the end of this year, we will have invested circa 3.4 billion real money, i.e. uplifted for inflation, into mental health services, and that's impressive. We've seen a big slug in the eradication of dormitories. We're investing that 150 million additionally in urgent and emergency care pathway alternatives to A&Es, trying to sort of do something really very differently. And that 77 million on critical bed gaps for mothers and babies. So there've been some really good projects and programs that you've been rolling out. You've been busy again during this challenge time. Do I think we need more investment in capital? Do I think we need more money to build local facilities differently so that we can stop what I consider to be the evil of out of area placement? Yes, of course we need more. We need more investment over the next 5 years as well, but some tremendous achievements there. Can we just go to the next slide, please? So I'm not going to talk much to this. This is just some data that we thought we'd include to my point at the beginning, really, which is we know that we've seen some big increases in prevalence and demand, and definitely the pandemic affected people quite badly. Well, I think it's the pandemic, like so many things, divided the country. You talk to some people who will say, I had a great pandemic. I, you know, was living somewhere nice with people I love. They were all safe. I didn't lose anyone. I wasn't lonely. I had a chance to reset life. I still have my income. It was great. For many, they were isolated, lonely, fearful, did lose people they loved. And for our children and young people, of course, school stopped. All of their usual routine stopped. We've got babies where we're worried about speech and language and socialising. So we know, and you can see there for many adults, we saw a huge spike in anxiety and depression as well. So it's just to note that. And let's be honest, we are at about 1.3 million people on our waiting lists at the minute, waiting for their second appointment, first to second appointment. So we know we have a lot of work to do still. Can we just go to the last slide, please? And I'll just speak for a couple of minutes, then I'm going to stop. So this is really to make the point that although we're celebrating lots of things we've achieved in the NHS, we have to continue to pay attention to the factors that absolutely contribute to poor mental health. And so we will be doing that with our many partners. But there are some things that we absolutely need to focus on this winter. The UEC pathway. We've done extraordinary work nationally, where we've seen at least 30% more people in our community services and seeing them in crisis in our community services. And we've held flat attendances at A&E where yet we know there's been an increase in demand, and that's because of the community alternatives. But when people go into A&E, we are seeing that the 12-hour, 24-hour, 36, 72-hour waits are longest for mental health patients. And in most cases, that's because they're waiting for a bed. We've seen the average length of stay go up nationally from about 34 days before the pandemic to nearer 54 days now. And we have to stay focused on flow and throughput and the discharge piece. We simply can't afford not to be discharging people. And I would say the system can't afford that. But individuals can't afford to be stranded in hospital either. We have to make sure that we're both avoiding admission, but that we're also got a really forensic focus on quality of life, support to leave hospital, and not create patients who stay a long time. And people have heard me say this before, but I'm not going to say it. I'm not going to stop saying it. This coming year, we're going to have a huge push on out of area placements. I think we spend a lot inappropriate out of area placements. We spend millions on them, on what is ostensibly poor care, as in we know it undermines safety at the point of discharge. We know that for individuals it's harder for their families to visit them, they're feeling stigma, they get put in ambulances in the middle of the night, sent 100 miles down the road. This really matters to people, so it's going to be a bit of a rallying call about that. And then I guess I'm going to be busy working with this region or this area and all colleagues across the country over the next several months on creating what are the must-dos in the next 5-year plan. We already know that there's still a bigger gap than we want around adult eating disorders. We already know, Tom and I, we want to do more joint work around autism and mental health and what we can do there. We know that there's a big issue with ADHD nationally. So we know that there's a lot we want to be doing in the next 5 years. And I'm rather excited, daunted some days when you look at how big a mountain we still have to climb. But actually, I'm really excited about the and what next, because to end where I started, when you look at what this sector achieves when it's given a chance and a relatively small amount of money relative to what our acute colleagues have, my goodness me, we innovate and we move fast. So give us the resource, we will use it well. We'll work with our patient service users, lived experience to go the next 5 years. So I want people to be upbeat, determined, realistic about the challenge, and excited really about what we do next. Thank you.
Thank you, Claire. A really great detailed overview. We have got a few questions coming in, but I'm going to leave them if that's okay, and we'll do them when we've had Tom's presentation, because there's a bigger collection. I've been looking at some as they've come in, but I think that really sets the scene in relationship to the position, the national position, and obviously going forward as well. And there's some questions that link into that. But I'm going to hand over straight to Tom, if that's okay, to give us a bit of a national picture on learning disabilities and autism. And obviously autism, let's talk autism today. Tom was a very senior chief executive in the NHS for a long time and has now gone into this national role for learning disability and autism. And as Claire said, working really closely with herself. I think we've got Gavin Hardy as well, who's one of the learning disability advisors. So good afternoon to both of you and welcome to our conference.
Thank you very much, and straight over to Gavin, if that's okay. Gavin, just wait to go live, and over to you.
Yep, my name's Gavin Harding. I'm a senior learning disability advisor in the programme, and I work in the transformation team, quality transformation team, which is between mental health and learning disabilities. I've been in NHS England for 8 years now, and I'm full-time as a national in the learning disability programme. And I work in the quality transformation team, as I said, in mental health hospital, doing focus groups and listening to people understand the experience of people in hospital. And I'm also do work on restricted practice, and I'm also the co-chair of the host oversight group with Norman Lamb. And I work hard to promote co-production and peer engagement to improve services, and I'm committed to making sure that people are there, not barriers to people leaving mental health hospitals. And as you know, I've had lived experience and lived in your area before I moved to West Yorkshire. Next slide. Yep, there are approximately 1.5 million people with learning disabilities, but around 7,000 people with autism in the United Kingdom in the National Autism Society predicted, but we think there might be more people coming through. There are people with learning disabilities are 2 times likely to have health problems and autism as well. And some of the health conditions are common to people with learning disabilities in the population. Diabetes is more prevalent in people with learning disabilities and autism in the general population. And between 9 and 10, 11%, the death rates are higher than from COVID. And people with learning disabilities in the general population of society and autism, because we're now looking at autism in the LEADER programme. Yeah, so next slide. Today we are talking to you about the Learning Disability and Autism programme, working for improving the health outcomes of people with learning disabilities and autism. We provide an update on barriers, and we undertake over the last year key barriers enabled to process and take some of the time to the future. But what we also, this programme has grown over the last few years since 2015, and there's been a hell of a lot of work done by us and the regions, and we know that you've all been working hard. And we know that you've also put people with learning disabilities and autism as your high priority. So it's the right workforce and skills and complex and values underpin the delivery of this commitment. And we know that's been hard for people to get workforce development as well, because a lot of people are retired and a lot of people left after COVID. So, next slide. Yeah. So this is our work streams: improving the quality care for people in hospital settings. And Tom's going to explain some of those bits of programme to you. Yeah. And improving provision of community services. And when we want, and that's about getting people back home and building, and right from the start in the programme, and improving the health outcomes and access to healthcare, because I recently had good healthcare where I am, and it's really good what I've received from people across the West Yorkshire patch as well. But I also received good healthcare when I was in North Yorkshire, and reducing the number of people in hospital. That's what we and North Yorkshire done really well with that, preventing people going into hospital and reducing the amount of people. And I know that you're developing that work in Hull as well and across East Yorkshire, and improving the outcomes for children and young people. I know that you've been doing a lot of work in the schools in North Yorkshire and Humber, because my sister's actually a head teacher in North Yorkshire, and she's actually told me about the services going into her school in the primary school, and improving the outcomes for autism people, and building the capability of workforce. And I know a lot of challenges have been happening around in your area for that. So thank you.
Thank you. I'll take on now, Gavin.
Yeah.
Just thank you very much, Gavin. Well done. Really, really spot on. Can I just drop back to the slide with all the work streams for a second? Michelle, my presentation is mostly about autism, but I just want to make sure that we land a reminder about some of the learning disability. So improving quality is a major part of our work now. You've got 65 adults and 7 children in hospital this moment in time. So what's the quality around those individuals? We know that we've probably, I think, 4 in long-term segregation. So quality is really important, and I'm really pleased with the quality transformation program that Liz Durant is leading. That's 36 million over 3 years. So we're really excited about actually, can we turn the dial on quality? Reducing the numbers. Clearly, we're seeing some progress, and I'll talk about that. We're seeing some people who've been in hospital a long time discharged, but there's still more to do. And I know within your ICS, you've still got to do more. On community services, we're really pleased what we're seeing nationally on a range of issues, which is key workers, creation of community teams. About 121 million over 3 years, which is going to be recurrent. Not probably enough, we know that, so we've got more to do. Improving health outcomes, we could talk all day about those. We need to really change the dial. Our new leader report is coming out next week. We can see some improvement, but we know that people are dying with learning disability, and autistic people are dying very young. So I won't pick up a lot of that today, but I will now talk about autistic people, if that's okay. So move to the next slide. So I saw your early slides earlier on today, and I think it's well recognised now the growth in referrals, in demand is really outstripping supply, and without a doubt. So if we move to the next slide, you'll probably see it in terms of graph terms. So this gives you a flavour, about 160,000 people waiting generally. Now, on one sense, I think, oh gosh, what's happening? But actually, when I look back on 2019, there were an average of increasing by 4,000 a month. Average referrals were 4,000 a month. They're now about 11 to 12,000. But actually, interestingly enough, referrals that were seen and dealt with were 1,000 a month. They're now up to 8,000 a month. So about 4,000 a month behind. But I think it's important that, I know your ICS and many other ICS are really working hard to actually see as many people as they can without a lot of new money. So move to the next slide. But we're also seeing this is impacting in terms of our inpatients. So on the green last slide there, some really good news. We've seen a lot of people with learning disability been discharged, and actually, in fact, 57% of people have been discharged. 80% of the people who were in the hospital in 2015 are no longer there. Similarly for learning disability and autistic people who've got comorbidity there. But actually, you can see the trend on autism, and that brings a question to us. How can we avoid those missions? And when they are admissions, are they going to the right place, and have people got the right skills and the right environments? And we know it is very different environments. Next slide just gives you a sense of children. Same story about children and young people. So of the 200 and so young people are in, we know that probably about 95% of those are autistic and autistic only. So what's the environment look like for those? Next slide. And we have the same again for young adults. A common trend there. So you can see across the board, not only do we have a community waiting list, we have a lot of referrals for people who are autistic into mental health services, and I'll say a little bit more in a moment. Next slide, please. So we begin to understand now what's happening and why people are being admitted. So if you just bear with me for a couple of seconds, I'll get this was between January 2020 and June 2023. Admissions were around self-harm, mental health disorder, and social and suicidal ideation. We also had about 17% of young people admitted for with an eating disorder, and also with learning disability admissions from 18 to 24 and 25 plus. Common reason was mental disorder, harm to others, and harm to self. And I think I know there was a question this morning when Baroness Hollins was talking about, okay, being admitted, but what's the care? What's the treatment? Is the environment right? Is the therapy right? And that is both for people with learning disability and autistic people. So what are we doing about it? If we go to the next slide. Our ambitions, as you would expect, firstly, improving quality and of access to all NHS services. That's A&E, urgent care, wherever it need be. Improving quality and access to all assessments, and we know and that's really, really important now. Reducing health inequalities. We know autistic people have the same prevalence of health inequalities as people with learning disability. Improve community support and provision for autistic people, their families and their carers. The quality of care for autistic people in mental health settings, and there's new guidance coming out soon on that will help people understand more about what people need when they're admitted. Education and social care are really, really important, working together, and we'll say some more about that in a moment. And there's a culture shift, an awareness that we've got to do is create an environment that people understand that autistic people need our support. It is not an illness, it's a way that people live, and we've got to accommodate that in the services we provide. Next slide. So there are three key prongs of our work that we've done. One is all age assessment pathway, which has just been completed, co-produced by clinicians and autistic people live, and that has been produced and published. So we're pretty excited about that, but we know that still won't increase capacity. What it does, increase consistency around quality. Reducing health inequality, autism health checks now are in place, pilots are in place. We're working with mental health around that health check. We want in developing guidance on NHS psychological therapies for autistic adults, and we're using the emerging finding from leaders. So this year's leader report will have for the first time the deaths of autistic people reviewed, and that will be really important for us to look at that when it comes. And then finally on this element, improving the quality of mental health treatment, really, really important. So guidance for people in mental health teams, in mental health hospitals, where people who are autistic people we know are more likely to have mental health problems than the rest of the population. So are we ready? Are our crisis teams ready? Are our community teams ready? And I know Claire's picking that up significantly with her teams. Supporting development of community infrastructure. And we need to understand what that looks like. And particularly listening to people with lived experience. It's not necessarily community and specialist teams, but it does really mean working with education, social care very early on. Two more slides, then I think would be okay, Claire. Michelle. So autism schools, really excited about this. 405 schools across every region, and we're seeing real benefits of that already. So picking up people earlier, but also bringing the expertise. And it is about expertise, confidence and skills. It isn't all necessarily highly technical, but people do need to be aware, do need to understand and work with families and their children. Next slide. We're also pretty excited about the work on key working. It's not just for autistic people, we were seeing it, but over 2,600 people, of young people in 22-23 who've come in contact. And what I know from the feedback is a lot of admissions avoided because of key working, and really works for people and families about helping them navigate the life they need to do. And then finally, next slide, we can't forget about training. Just going. And I clearly we're all going to talk about Oliver McGowan and from his tragedy, from his legacy to what is fantastic training. We've got over a million people now have completed first part of tier 1. and we're really excited about that. So we're encouraging everyone to really get on board and do that training. It is fantastic in awareness. It creates, there's a lot of key messages in there, and you're hearing directly from people with lived experience. So that's a quick canter through. I think my next slide is just for questions. If you just move to that, just make sure I'm not missing one. There we go. So Michelle, I'm going to hand back to you, but I hope that's helpful for people.
Perfect, thanks Tom. It really, again, it sets the scene, doesn't it, for the questions, and we've got a bit of time for questions, and we've had some that's come in, and I'll bunch them together. What we are saying is, if we don't answer every single question, what the team will do is go through the questions, and where we can, either bunch them together and respond when we do the feedback from the session, or get individual replies, because there's some individual things on there which we'd obviously rather not go out into a wider domain, but we will get back to you. So just some of the things, thank you to Claire and to Tom, and obviously we mentioned about linking very closely together, which I think is really important. But one of the things that I think the theme has come through a bit about the gaps in services between, because a lot of them are specified in relation to, it's particularly about autism, around particular ages or particular service groups. So what are your thoughts on that? Do you want to have a bit of a conversation about those gaps? Because I think from a provider point of view and from a collaborative point of view, we try and do all we can to alleviate that, and that's why we utilise other sectors as well. But it is, to be quite honest, it's still there, even though we are trying to work really closely. I just thought, if you had any thoughts about it. Tom, do you want to kick off, and then maybe Claire?
Thanks. I think there's a conversation to be had about what does a community resource look like, and the conversation I know the mental health teams are talking about is that, are they equipped and have they got suitable training to look after people who are autistic? We have this conversation, and it's people with the lived experience and families that will give us the best guidance here. But we have this conversation about, we know that people often require specialist learning disability supports, and therefore we have specialist teams. Do we need and do we have specialist autism teams? And there's a conversation to be had there. We know there's an issue around capacity. There's no doubt about that. And we know, and we're putting significant pressure, Claire and I and colleagues, on the next spending review about, have we got the appropriate workforce? So I think workforce and training are probably the two biggest things for me. People who are suitably qualified, have the background on autism, know from experience, and then are in the right place. And that doesn't necessarily mean unique teams. It means being embedded within teams. And you've seen our first response earlier. Our first challenge, our first ambition is that anywhere in the health service or social care service, people who are autistic have ready access to people who know how to look after them.
Thanks, Tom. Anything, Claire, on your relationship to that?
Well, I think the only thing I would add, I mean, there's so much we could say about this. When I spoke, I talked about having worked in the NHS 40 years and probably having been angry for most of them, and angry at the kind of burning injustice of the lack of parity that we still have around access and waiting time to treatment. I'm excited that in recent years we've started to turn that oil tanker, but it's job begun, not job done. And I think one thing that's happening today, I think, will be the first publication of what will become a routine publication of waiting times across children's and adult services in mental health, and particularly we're focusing on the longest waits. Now, Tom and I have been looking at these because some of those will be CAMHS referrals that are actually for autism assessment or treatment, or will be CMHT referrals that similarly will have autism and in there. So we think some of the longest waits are in that area. The reason that having the right data, having the waiting times, publishing the waiting times is so important is we need to shine a light on where we need new workforce, new investment, new innovation as well. Let's use technology. Let's make sure that we're world leading in anything new we do. But we have to get very, very serious as an NHS at counting and shining a light on the treatment gaps. So I'm excited today, and I know a lot of the media are waiting for the publication of this so they can write another bad news story about the NHS probably. But actually, guess what? I welcome, and I think colleagues here do, I welcome a light being shone on these weights and having the data alongside family and patient experience to describe what that means vis-a-vis things like affecting school attendance if you're a child, affecting your ability to work if you're an adult. So I think we all just need to be very honest about that gap and work together to make sure that this government and the next government take it seriously and work with us.
Yeah, thanks, Gail. That's a really important point, and I think one of the things
Can I
that.
just come in here a minute? Yeah. Because I'm just
Sorry,
gonna,
Gavin. Absolutely, Gavin.
can I
Yeah,
just come
absolutely.
in here a minute? I just
Absolutely.
if a football club like Arsenal can adopt autism friendly box, then a hospital must be able to adopt an autism friendly ward. And that's what I say. If sporting events like that can adopt executive boxes, then surely a hospital will be able to adopt an autism friendly ward altogether. So we need to challenge ourselves and make sure that happens.
Absolutely. I mean, it's actually a great way to end the conference on, Gavin, really. And I will say that at the end, because I think it is about challenging ourselves, isn't it? And that curiosity. But what an absolute great point. And thank you. Absolutely. I mean, just touching back on Claire's point about waiting lists. I mean, I think it will be really helpful to get that in lots of respects, the waiting time information. And it links into a couple of questions that we have had, which is around, because we do a lot here on our waiting times, both as an organisation, but also as a collaborative around assessing it, making sure that we've got some support for people that are on the waiting lists, obviously trying to do a lot of work with other sectors so we can actually minimise those waits, but obviously they still are longish. But the question was, I think it was a really helpful question, is what I'm going to actually take away as well, which was around, and you may have some examples, and Gavin may have some examples as well, which is around self-help whilst people are on waiting lists. So do you have any experience of that? Anything you want to share? I don't know, should we start with Tom and then maybe go to Gavin and then Claire, but Tom and Gavin, anything from you?
Yeah, I think it's around having family and friends support as well, and also help. There is voluntary sector groups out there who can help people, but it's about professionals knowing where those good support groups are out in the community, and that's what we need to encourage them rather than prevent people going into hospital, and actually having specialized trauma services for people in the community, and using our third voluntary sector and putting investment in it.
Yeah, thank you. So I absolutely, some really great things about access and how you can get it and where it is as well, and family and carers. And there is something as well, a question which I'll come on to in a second, which is around support for carers, because we've touched on that a little bit, but I think it'd be useful maybe to touch on that as well. But anything else, Tom, on that point?
Hi. I'm visiting somewhere recently, and they reminded me about what they're doing around support for carers and self-help, and the two things come together. In terms of their waiting list, what they're doing is checking with families and have families got the right skills and training. So siblings are really important people when as part of that family, and actually not looking necessarily for the NHS route or the highly specialised route, but just checking and signposting as Gavin talked about. And what we're finding is actually quite a lot of the referrals are actually getting addressed at that end. Now that's not to say that people don't need a much more thorough assessment, but if we start to look at a needs-based rather than a diagnosis-based, you begin to think, okay, what are the issues for that family? Can you help that family a bit differently, and can they help themselves? So that's what we're seeing up around the country in terms of people finding, people who are on these referrals waiting for this diagnosis, maybe providing an alternative for them.
Thank you,
And
Tom. Anything for
also-
yourself, Claire? Sorry, Gavin. Sorry.
Also,
Well-
we've just got to be realistic what we can deliver as well. Yeah, and not overstretch ourselves, because that's where the problem's been with parents and their support.
Yeah, it is good, and I think sometimes, and that's where the carers assessment comes in, isn't it? But yeah, really good point. Thank you, Gavin. Anything finally for you, Claire? We'll have maybe one more question, but anything on this particular question, Claire?
Well, just
go
two
to the
things.
last one?
Thank you, Michelle. Just two things. As you said, Michelle, bravo, Gavin, for raising the point that we need more autism-friendly environments, whether that's in employers, in schools, in everything we do. I mean, in the NHS, when staff self-report whether they work with a disability, some of the most unseen colleagues working with a disability would self-identify as having autism, or have a diagnosis as autism or some other neurodevelopmental condition. They're a huge asset to the NHS, those colleagues. And I think certainly I know in my own trust, we're working with our neurodiverse network to say, okay, help us be a more neurodiverse and better employer. And I think if everybody did that, actually you would create natural networks of support for people without the NHS in fact having to be involved at all. And I do believe in that sort of people power. And on carers, look, I couldn't agree more about, I'm in awe of the work that our carers do or loved ones do. I know some people who seriously object to being called a carer when it's they're a wife or a mother or you know, but we all know what we mean, which is really without their vital support, all services would be overwhelmed and life would be much less happy. I am hoping that places and ICBs and ICSs will think really seriously about how working with local authorities and third sector organisations about how you build local community assets and make them available across, because I think there are so many great groups that exist that we just fail to connect people to. So I think we all need to take that connectedness and how we do that very, very seriously.
Yeah. Okay, thank you, Claire. I'm going to just to stand on this question because it has come through quite a lot all day, really. Then I'm going to ask Gavin maybe for the final part before I just do a very quick close. But just about out of area placement, and this is really for you, Tom, because I know that you're working tirelessly, and trust me, Tom is working tirelessly. We have lots of conversations about out of area placements. But just to summarise, Tom, where we're up to with that, you touched on it in your presentation, but we've had a couple of questions since, and I know it's something that you're giving a lot of commitment to alongside everything else. So just maybe just a very few headlines on that would be really helpful.
Thank you. I'm waiting for red. Thank you. I'm waiting to come on red light.
Yeah, I think so. Yeah, I think so. Yeah.
Thank you.
Yeah.
Out of area is a significant issue for us, for people with learning disability and autism. And I think if you go back to the history and my experience since I've come on board in this program, it is about commissioning and where we commission services. Now, there's very many of our people who are out, and we will argue that they probably shouldn't be in beds. And when we done the review of everybody's safe and well-being, we found that about 40% shouldn't be in beds. That said, we know there are people out of area receiving appropriate care, and we're asking about, well, why can't that be delivered more locally? But equally, we know that people are out of area is also a quality issue. They tend to get left there longer. The level of care is not always where it should be. So we're majoring in that. So there's two parts. We're saying, actually, do these people really need to be out of area? And can we get them back closer to their families? And there's significant work there. Can we get them discharged from that area? But if they do need to be there, have we got proper oversight? Have we got proper, and is there really something we can do more of to make sure they improve that quality, so that length of stay and things like that are greater? So it is a significant issue for us. And if you look across the country in terms of the number of people who are a long way from their community, I'd say, rather than homes, it is something we will continue to do. So even if we meet the targets for people with learning disability around achieving a 50% reduction, we know there's two things: people in hospital too long and some people too far away from home.
Thanks, Sam. And finally, Gavin, just to put you on the spot, before I do my little summation of the session, is there anything you want to leave us with? Any comment that you want us to take away and think about?
Yeah, I just want to say something, actually, because we need to, and also when you're looking at your workforce, right, if you want a really experienced employed people with autism or learning disability in your program, because we've employed a lot of people in NHS England and family carers, and we've got also mental health advisors now in the team, and also the out of area placements. Yeah, what we don't want is people being moved to an inadequate hospital where they're getting poor care, and that is one of the things we have got in policy on the national team, is not to move people in an inadequate hospital, and just keep checking on people and making sure that people who are out of area are not in long-term segregation either. And that's where the key message is. But also, it's the people who can't verbally communicate in the community as well that you need to be looking at and assessing whether they're getting the right needs and what their future is, because there's a lot of people still living with their families, and their families are getting older, and it's about making sure those people are not going to deteriorate after their families depart this world, really. Yeah.
Thanks, Gavin. Thank you so much. And what a great way to end the conference. And can I again thank Gavin sincerely for some fantastic input, Tom for equally great input and a real overview of the national agenda, and Claire as always for the national agenda for mental health, as well as the learning disability autism, but also the support from both Tom and Claire. And we mentioned funding a few times in the box, but I know how hard both Tom and Claire, and we shouldn't have to, but I know how hard they do work in relationship to funding and keeping the funding really on the agenda for mental health and learning disability and autism. So thank you so much. I've got a couple of minutes only. I didn't do as well as my earlier colleague on keeping everybody to time, but I think it's important that we had that question and answer session this afternoon. So what a fantastic day. It is my privilege. When we started this 5 years ago, we never thought we'd be an international conference with hundreds of people attending. I think the second time we did it, we did get a couple of international people, but I know we've got a few this year from all over globe. But thank you all for your time as well, because time is precious to all of us and it is appreciated, your support. But what a great session we've had from my art breaks this morning, which was around autism and people in mental health settings, and just to hear there's still too many people, autistic people in mental health settings. I think we have seen a reduction of about 30%, but still over 2,000. It is too high. These are some of the key things that we will need to take away as a collaborative. But Jill's takeaway around we should always take away what and reflect back to those, and all the way through is that communication. A few people have said that, and we've seen this user involvement throughout. But one of the things that just stand in my mind, I think it was Lindsay that said it this morning, is from small seeds grow bigger trees, and how important is that? So sometimes just try something that's very small and let's just see how that progresses. So fantastic. I could go on. We also launched our annual report today, so that will be in your inboxes soon, and that just sets out a little bit about what we've talked about today. We will send out the slides, so please have a look at those. I could thank loads of people, because these conferences don't just happen. Getting everybody in the same place at the same time with the sound is amazing. And Emily, David and Kelly Toes Smith particularly need a great round of applause for managing to do all that. Thank you for all your questions. We've had over 210 questions. We will, as I say, summarise those. And we will send out a bit of a feedback form. So please, I know it's difficult when you get things in your inbox, but really helpful if you get those, because we set the themes for next year. We did health inequalities last year, we've done autism this year. So help us decide what you want us to talk about next year. But I'm going to end up with a comment from Gavin, which is around workforce and employing people with lived experience and autism, and that professional curiosity. And I think if we go away with those things in mind, we will improve and continue to develop the services for autistic service users as well. It gives me great pleasure to work in this field and be a nurse by background. And thank you so much for everybody that's listened in today, for all our speakers, for all your questions and time. And we will get back to you with various answers, various themes, the slides, etc. But let's keep communicating, because as we've said this morning, communication is a great key. Thank you. Safe journeys and safe wherever people are going.